Okay, everyone, good morning. Very welcome to the first live streamed meeting of the Northampton Hospital Trust Board. We have no apologies today, although I am aware that Mr. Archer-Jones might need to disappear to decide on the guilt of somebody as part of his jury service. So we'll know what's happened, John. Any declarations of interest? Tremaine, yes.
So I should declare that I've taken the role as Head of Emerging Technology.
Okay, thank you for that. Let's record that. The minutes of the public board meeting on 28th of May, are you happy to approve them as a fair record? Nodding will suffice. Anne? Anne? You're muted. You're muted.
Sorry about that. Bottom of page 11, it says that I conducted a Zoom call with the Bain Group. I haven't, but I think Mark and Sonia did.
Okay, corrected. Anything else? Are we happy? Yep, we're all happy. Good, thank you very much. Matters arising. There is an issue about the risk register, but I think this is with the two directors of governance, and they have agreed that the risk registers between the two trusts will mirror each other. Now, arguably, there is another risk which our chair of audit talked about, which is risks which only arise because we're a group. And we'll be thinking about those in a slightly separate way, but in any case, those risks will also be in a mirrored risk register between the two organizations. And we'll tidy that up and make sure we fully understand that from a risk register point of view in due course. Is there anything else on the action arising? No. No, good, thank you very much. We ought to welcome Simon Weldon here as his first board meeting as a new group chief executive. You're very welcome, Simon, and we hope you enjoy your first board meeting with us after only a month. So we're not expecting you to know everything that goes on in Northampton, at least till next month, but you're very welcome. Straight on to patient and staff vlogs. Sharon, you're going to show us a couple of videos, one from a patient, and then Matt, you're going to, I think, lead one from a member of staff. Is that right? Sharon, over to you.
Thank you very much, Alan. Our first vlog today is from one of our patients, a young lady named Karina, who I've had great privilege in having conversations with over the course of the last few weeks. And I'm absolutely delighted that when invited, she agreed to tell her story. So the impact of having an illness during COVID. Kieran, can you play, please?
Hello, my name's Karina Quarterman. I'm 29 years old and I've had a condition called reflex sympathetic dystrophy since I was 12, but not confirmed until I was 14 at Birmingham Children's Hospital. I've been under the care of Dr. Jeffrey, the rheumatologist, Reggie, who works in the pain clinic, for about 12 years now. I've been having a treatment called a radiofrequency lumbar sympathectomy block. This is where a needle is put into my spine. I'm injected with steroids and the nerves are pulsated away. I was given this treatment after trying so many other options such as physio, hydro, acupuncture, TENS, anything you can think of. I've had it, all of which were unsuccessful. Complex regional pain syndrome, which the condition is also known as, is recognised as being one of the most painful conditions that you can have. It's degenerative, and I've deteriorated so much since I was first diagnosed. I have problems with my heart, my stomach, causing me lots of sickness, gynae problems. I have a really poor immune system, and for 2 years I've had bladder failure, which has led me to have a suprapubic catheter fitted. I get excruciating pain, and the pain blocks I have them every 4 months. This has been an ongoing thing for quite a while now, and I'm talking many years. and this was fought for me by my doctors and by the rheumatologist. The blocks I have for 4 months last really about 3 months, but I can't have them more regularly. In the last month, I get really, really poorly. I can hardly get out of bed. I get sick. My foot and legs are blue, swollen. They feel like they're on fire. They like mottled, but they're actually freezing to the touch, usually around 29 degrees. I walk with 2 crutches. I have to use a wheelchair and a scooter. I have problems with my joints as well, and I walk on crutches and on my toes because I've got a shortened and fixed Achilles tendon. The block I have has been managing my pain relatively well. It's something that has made my life bearable. Don't get me wrong, there's been times in the past where the pain's been so excruciating I can't see a way forward, but without my block I don't know what I would do. I'm still on really, really strong tablets, but the block is everything. It means that for those 3 months I can actually do some things, and I'm not stuck in bed and I'm not crying in pain and wanting to rip my skin off my foot. COVID has affected a couple of things. I was due to have a meniscus repair of my knee that had to be cancelled in April. I've had this problem for about 3 years now, but I'm very aware of the surgery causing the RSD in that knee. And most importantly, the blocks have been cancelled. I spoke to my consultant, who has also now told me that because I've got such a poor immune system, the steroids she gives me also suppresses my immune system. And because I keep getting bladder infections and infections in the catheter site, she's too frightened to do the procedure because it's introducing infection into me, and she's worried I won't be able to fight it off. I've asked when things might be going ahead, when I might have that option, and she said that the treatments aren't even being done in the clinic yet, and that even if they were, she wouldn't want to do it till at least the end of the year, maybe into next year. Now, I was lucky I got to have it in January, but I'm well past my due date now for it, and I'm in absolute agony already, and I can't bear thinking how much further I'm going to be, and I don't want to be back to square one and how I was to start with. So COVID has really, really messed up things. My pain was manageable, so not only has COVID affected those that have had it.
She's okay. She's okay. I'm in regular contact with her, and checking that she's getting the support that she needs. But I think she's been very honest and open in the vlog that she's shared with us, and we have to realise continually that, as you've said, Chair, that the impact of COVID affects so many people in so many different ways.
Okay, anybody else? You're muted, John, if that's you.
Yeah, I've got some questions, but I'm not sure I should ask them in public because I think it might compromise the patient's privacy. So maybe, Sharon, maybe I could have a private chat with you on that. Okay. I don't think it should be done in public.
Okay, Matt.
Not in relation to this individual, but of course her story will be replicated thousands of times throughout the county. And as a trust, we're acutely aware of the impact of delayed planned care for immediately life-threatening conditions. And we're working very hard to establish a COVID-safe zone so that we can start to safely reintroduce some of this elective care. And the reason that we have had to be so cautious, despite stories such as that we have just all heard, is the devastating impact of contracting COVID in any kind of perioperative or periprocedural situation. But listening to that story has only made me want to redouble our efforts to get a COVID safe zone up and functioning effectively as quickly as possible.
Yes, you can't really imagine it's beyond the wit of man to find a place for patients like that that is completely COVID secure. So perhaps you could just keep us aware of what's going on with, well, that patient in particular, but more generally a COVID secure place for patients who have urgent needs, or not life-threatening necessarily, but urgent needs for treatment. Thank you, everybody. Done? Yeah. Okay, Matt, you have the second video.
I do. So Brian is a very long-serving member of the team here at Northampton General Hospital, and I'd prefer to let him introduce himself and tell his own story. So with no further ado, Kieran, please could you?
Good morning. For those of you who don't know me, my name is Brian Richardson. I'm a consultant chest physician and I've worked in Northampton for the last 20 years. I've been asked by Matt to offer some reflection on the recent COVID situation, and I think this can be both professional and personal. From a professional perspective, I was part of something called the Respiratory Support Group, which was a group of experienced respiratory physicians and intensivists who essentially were working from home, offering support to staff, both nursing and medical, looking after COVID patients on the ward. I was able to view x-rays, blood results, observations, etc. from a computer at home, which allowed me to keep an oversight on all of the patients on all of the wards, rather than just looking after patients on one ward, which I arguably would have done had I been at the coalface. I think I found the situation challenging in that I worried that I was being protected at home in my study, which I was undoubtedly grateful for, whilst colleagues were on the coalface with increased risk of contracting COVID themselves. I think some of my consultant colleagues also felt that it was ironic that what they perceived to be a chest illness, a respiratory illness, was being looked after by them when the respiratory physicians were at home protected. I found that emotionally quite difficult to cope with. In terms of the benefit of the respiratory support group, I think others will have to make a judgment as to whether it was something that was valuable or not. I certainly found it proved to be useful, particularly for the physicians who were drafted from non-acute medical specialties to take part in the acute medical take and look after COVID patients. I got many calls from such clinicians. But I think the most value I perceived of the respiratory support group was the support that we were able to give to the junior doctors and indeed the nursing staff in the middle of the night when perhaps it was not appropriate for them to ring the on-call consultant. On a more personal level, some of you may know that I myself contracted COVID. I didn't suffer any of the cardinal symptoms that the government were warning us about. I never had a temperature, never had a cough, and that's despite having extensive abnormality on my chest x-ray and CT scan, and indeed needing to come into hospital and be supported with oxygen and CPAP. The other thing that I would wish to stress from my personal experience is the level of support and good feeling that I received from all members of staff. It was incredibly humbling on a personal level to feel that level of warmth and goodwill, and it made me realise, perhaps reinforce the fact that we are colleagues, we are really a family, and we mustn't lose sight of that. The care that I received whilst I was in hospital was absolutely fantastic, and I can't fault a thing. Personally, I was a little reluctant to consider escalation to the intensive care unit. In retrospect, it was absolutely the right thing for me to do, but personally, I felt that If I could stay out of the intensive care unit, that meant I was one step further away from being ventilated, which meant I was one step further away from succumbing to an illness that was taking people of my age. That was really my motivation. The further away I could stay from being ventilated, the more likely I was to survive. I can't say strongly enough how absolutely wonderful the care was that I received, both on Esther White and on intensive care, HTU. The nursing staff were brilliant, and they were very aware of my vulnerable position as a patient, but also as a consultant in the hospital. And again, I cannot thank them enough for that level of perceptive care and support. The other thing to say is that generally I was overwhelmed and indeed humbled by the level of strong positive feelings and goodwill that I received from colleagues of all grades and all specialties. And it made me really feel that although this is a huge organisation, we're not really just work colleagues, we are a family. And I think that is hugely important to the running of the hospital, and we must try hard to maintain that. I think on further reflection, the level of coming together that this situation has engendered has been fantastic, and I think the hospital has sort of come on leaps and bounds in respect of camaraderie and hard work and ideas, and we really must strive to keep that. The other thing to say, really on a personal level, is just the effect that the situation had on my family. Unfortunately, they weren't able to visit me in hospital, which I perfectly understand, and indeed they did, but I don't think we should belittle how difficult it is for families in this situation, and I think we must keep sight of the impact that this is having, not just on the patient but on family members as well.
Thank you. Again, pretty humbling stuff really about what people went through and their families did. Anybody commenting on that at all? I presume our colleague is fully back at work now, looking at his video now, Mark. Yeah, and as fully recovered as people who've been in ITU are. David, you're muted. Good.
No, just to say that really was a very moving and, as you say, humbling story from a personal perspective. But the piece that got me, I think, was the fact that, you know, the sum of the parts is greater than the whole, which is what he was saying. And that is a spirit which I think we've really got to keep going as we move out of the COVID period, and try and develop our organisations around that spirit.
Okay, thank you very much. Let's just remember some of the thoughts in those two videos when we have some other decisions to make about how we take this forward, and maybe particularly when we start talking about the reset paper, which comes later in the agenda. Okay, Chairman's report. Well, I've already welcomed Simon, but we ought to formally acknowledge the fact that he did take up post on the 1st of July. And of course, Sonia Schwartz ceased to be the chief executive at that point, although is still around in the building a little bit until the end of this month, in other words, tomorrow, when she's going on to do other things which will be of benefit to the health service. So you're very welcome, Simon. Capital monies, it's worth recording that we've got some £26 million in total to build our new ITU, which is going round about the south entrance with a rerouted road and to the rear of our current operating theatres. And we've also got money in that sum to completely replace our generator capacity. And some of us will remember more than others what it was like a year and a bit ago when our complete electricity failure across most of the site occurred in the middle of the night. So a replacement and upgrading of all our generators will no doubt make Stuart Finn's life a little bit easier, but also everybody else in the hospital can can sleep a bit more easily about an absolutely secure electrical system. It'll obviously take a little bit while to introduce those things, and the money covers this year and next year, but it's a very clear commitment from the government to increase ITU capacity and increase the safety of the hospital. A couple of appointments to mention. One is Debbie Needham, who was appointed as the Managing Director for the NGH site on an interim basis. We will be going out to advert for that later in the year, but there's quite a few little hands clapping there. So well done, Debbie, you're very welcome. And I'm sure everybody here is keen to support you and make your appointment successful.
Thank you.
And the second one is Mark Smith as permanent Chief People Officer for the new group. And I've just lost Mark on the screen somewhere. I haven't got, oh, there he is. Yes, so congratulations, Mark. And I know both of those interviews were actually pretty rigorous. I know that because I was chairing them. And we're pretty pleased with the appointments we've made so far. Further appointments to the group will, of course, follow. And that will be reported in due course. Simon, I think, mentions it in his report. And the final thing to say is that Paul White, who's been the interim chair of the Healthcare Partnership for a bit over a year, has now stepped down from that role, and the post will be going out to open national advert for a, I'm going to say permanent appointment, but I think it's a 2-year appointment, obviously renewable, given all the changes likely to come in the role of healthcare partnerships and system leadership in the next couple of years that are being flagged up by government. But anyway, Paul has decided to step down, so we thank him for the work he's done for the last year, and we look forward to appointing to an open national appointment process, and we'll see who we get for that. Any comments on any of those, apart from all the hand claps for Mr. Smith and Mrs. Needham? Nope. Okay, thank you very much. Simon.
Thanks, Alan, and thanks for your welcome. Can I just start by first joining in your congratulations to Debbie and Mark. It's great to have them both in their new roles. The success of our group will be founded on the people that we get to come and do these really senior and important jobs, and I think we've made a really great start with both of those appointments, and I look forward to working with them both in their new roles. I want to say a few things. The first is, just from a personal perspective, the video stories that we saw this morning were both very powerful for different reasons. And what they make me think about is indeed what I start my report with, the fact that COVID has had a huge impact both directly on those people who've had the illness and their families, but also maybe those people who have been, whose treatment has been compromised. And as we sit here at the moment, Northampton is in the middle of being watched. It is currently under scrutiny because the level of infections has been rising. And it reminds us, I think, of two things. One, that the virus is still very much with us, and therefore it's incumbent upon us all to continue to take all the precautions necessary to minimize the spread of this horrible illness. And I summarized for you all the latest advice from the public health system that applies to people in Northamptonshire. And I know Debbie, Sharon, Matt and others led conversations across the hospital to strengthen our precautions around visiting and appropriate PPE at all times and in all places in the hospital. But what those stories also tell us is that we have got an NHS to run, and as we continue to live with COVID, because it's not going to go away, we're going to have to find ways of developing, not only improving our response to the illness itself, but also keeping the services open for patients. And I think we've now got not only the challenge of responding to when a COVID second wave comes, we've also got to really think about how how we continue to provide core services for patients, because the story I think Karina told was incredibly powerful in that respect, and she is at the tip of an iceberg of patients who have, for one reason or another, not been able to access the care that they would have ordinarily been able to. And I just want to say to her directly, we will do our very best to reach out to you and do better as we go into this second period of dealing with COVID. We know also that in dealing with it, the work that we have done and need to continue to do with our partners will be key. And I don't just mean our partners in social care. We know that one of the things that really made a difference and frankly prevented us from being overrun in the first phase of COVID was that people in our communities really stuck by lockdown, and it made a real difference. Some of the early estimates that we saw about the demand on critical care beds would have been that we would have faced a real challenge. We didn't face that challenge, and that's because in part we took extra efforts and super surged our capacity in critical care, but also because everybody in our entire community and our entire system locally bought into lockdown. And I think it will be incredibly important that those precautions are maintained going forward. And finally, I'd just like to again add my tribute and thanks to staff who've been phenomenal in terms of keeping all the services going. And I think Brian's story was testament not only to the care he received, but to the care many hundreds of people received as they came through Northampton system. I want to say just a couple of words on the group. I've included here a slide which comes from the words of the staff who we've been talking to thus far. I guess I could say a lot about the group, but the only thing I really want to say today is that I think we have to approach it with a spirit of optimism. I was very heartened to see that word, or those three words, opportunities, patients and staff, coming so strongly out from the initial feedback that we've had. And I think we need to hold those as our watchwords as we go into the work of developing the group. I'm going to do my best to be an expert, Alan, the next time we come round the board meeting. And I'm also going to do my best to maintain a kind of sense of optimistic spirit. It's often easy sometimes to get dragged down into the weeds, the detail, but we need to remember here that we've got a huge opportunity to do things differently. Just a couple of other brief points. Firstly, I think I'd like to thank everybody who was involved in securing the capital for the rebuilding work and for the new ITU, in particular to acknowledge the contribution of Phil and his patient lobbying and persistence above and beyond the call of duty to keep that flame going. It's going to make a real difference. The plans that Stuart showed me are genuinely exciting. It will give us a fantastic facility for the people, and I think, in fact, those might be the pictures of the plans in Stuart's background. So I just remember seeing them. So if you're interested in looking at them, you can see them there on the live stream. That's what the new IT unit looks like, and it will give us a fantastic facility for Northamptonshire. Real game-changing stuff. We need to get on with it now, and I'm really looking forward to seeing those plans developed. To one particular comment today, I'd just like to finish by paying my own tribute to Sonia. I think the best thing I can say about Sonia is probably contained in the two videos we saw at the start. They reflect everything she would have wanted, I think, to be said about the hospital, and the most sincere tribute I can pay her is just reflecting and listening to the words that people, both the patient and Brian, used in their summing of what had gone on. And so I just wanted to acknowledge and say thank you to her. That's it, Alan. Thank you, and happy to take any questions.
Muted now. Any questions or points from that? I think you're right, Simon, about the responsibility of the board to, I mean, we have got a hospital to run, but we've also got a group to develop, and we've got a sense of optimism and opportunity here for staff careers and for services for 800,000 people, not 2 hospitals for 400,000 people. And whilst that may sound like a rather trite phrase, it actually makes a huge difference to how you provide services. And in the last month, we've appointed our first 2 clinical leads, as you mentioned, and I'm sure there will be more of those as we start to think about how services are best provided for the county rather than half the county. So, anything else at all from that? No. Okay, integrated governance report. Can I just make the point that there is a later paper on the agenda, which is the reset paper. So let's try and keep the integrated governance report short, because the majority of the meat of this stuff is actually in the reset report. And if we could try and avoid talking about the reset issues, I know it's quite difficult to separate the two, but we could try and avoid talking about the reset issues until we get to that bit of the paper. I just think it will make the meeting flow more smoothly. So, how are we starting this? Are you taking charge of this, Debbie, in your new role, or?
I think Sharon's going to start with her update.
Okay, on you go.
Thank you.
Thank you very much. I'm going to start reporting on the aspects of the scorecard that fall within my responsibility. There's 2 areas I want to speak about. Firstly is the friends and family. That's the way in which our recommendation rates are calculated. That's been suspended due to the pandemic, and we've been notified that that is likely to be recommenced again in September. In the meantime, we've been collecting our local satisfaction levels by using SMS messaging and automated voice calls. When we've got sufficient period of time and data collected, we'll be reporting on that, but I can say at the current time I have no cause for concern. I've also reported on the scorecard that the NHS England had paused their complaints process on the 29th of March. I'm able to confirm that that's been reopened on the 29th of June. To report to the board that at the time of the pause, we had 15 complaints open at that time. At the point of reopening, we only have 4. During the pause period, we had 49 new complaints received. They have all been triaged and the complainants have all been contacted. Timescales for response has been agreed with the complainants. So I want to provide some assurance to the board that that's all in hand, and I'm not expecting there to be any significant issues or concerns that arise from that. That's all I wanted to report now. Thank you.
Okay, thank you for that. Just as a general comment, I think all chairs of committees are aware that from our next public meeting anyway, we'll be looking for this section to be reported by chairs rather than by directors, with a very much a view to raising those issues which committees feel we need to escalate to the board. And part of that will obviously be clarifying and maybe repeating in some cases the devolved responsibilities and authorities of the committees, but we'll get that sorted in time. So chairs are aware of how we're going to handle this rather differently in future. Any comments on Sharon's report? No. Debbie, it'll be you now then as the Chief Operating Officer, or as the Managing Director. Tell me more.
Thank you, Chair. So the report I'm going to take by exception, as you rightly say, we've got a more detailed reset paper later on in the agenda. So I'll just give you a brief overview of performance. A&E performance to start with, that deteriorated in June down to 86.9%. I am pleased to note though that performance in July has started to increase again and is currently over 94%, which is good news. And we are within the top quartile in terms of benchmarking with other trusts as well throughout the country. That's really good news. I'm really pleased with the work that A&E have done. The deterioration in June was predominantly around an increase, a start of an increase in attendees to A&E, and the team starting to get used to how they will manage social distancing and the use of PPE. In terms of activity through A&E, we have started to see a gradual increase as the months have gone on from April, but we are still on average around about 100 patients reduced every single day through the A&E department. In terms of cancer, so our 62-day performance for cancer still remains a concern. Our performance in May was 68%. Just to compare with the national performance, national was 69.9, and within the Midlands, performance was 62.4. So better than the regional performance, but just less than the national performance. Cancer for me is going to be one of the big priorities moving forward over the next few months, and I'm really committed to making this better for our patients. With regards to referral to treatment, so this is our elective, generally just routine patients. The average wait for referral to treatments increased. Last month it was 13.1 weeks, and it's increased again in July, unfortunately, up to 17 weeks. And of course, you would expect some of that to start to increase because of all the pauses that have taken place and the fact that we haven't been able to do as many outpatients and as many operations. And also the fact that we've prioritised cancer and urgent patients over routine. So I'll stop there on the numbers, and happy to either pick up any questions now on the numbers, further discussion later in reset.
Okay, anybody picking up anything there? We'll take it in the reset, I think. It looks clear to me. Okay, who's next?
I think we're passing to Phil next.
Okay.
Morning, everybody. I'll take the slides as read, but wish to add the following. Trust remains on a block contract with top-ups to cover loss of income and the cost of COVID. These arrangements were due to end at the end of this month, but have currently been rolled forward into August and likely into September. We spent £3 million in June on COVID-related items and require an additional top-up of 2.8 million. As the chair and Simon has said earlier, really pleased that we've got the money this year for the new ITU and to complete the electrical infrastructure. That's going to make the hospital so much more resilient and provide some superb facilities moving forward. On the 22nd of July, we received a letter from the Department of Health and Social Care detailing how our balance sheet debt will be converted to public dividend capital. This will be completed by the end of September, and this will remove loan interest charges going forward. At yesterday's Finance and Performance Committee, we presented a balance sheet review. This was in response to issues in a local trust around balance sheet, and obviously we was able to provide assurance to the committee on the figures that were contained within our balance sheet. That was all I wanted to say, and happy to answer any questions.
Okay, anything on that? No. Mark.
Thank you, Chair. So in a similar spirit, I will take quite a bit of the information in relation to attendance and absence in the reset programme and how we're supporting colleagues also through this next phase. I just wanted to pick up a couple of things that we talked about at the Workforce Committee last week, which was around vacancy and how we are looking to switch back on our international nurse recruitment campaign and bring colleagues back bring colleagues over to join our workforce, but also to focus our attention on our domestic supply of nurses. So if nothing else, the recent pandemic has demonstrated the commitment to the National Health Service, and none more so than the number of students that came forward, both from a medical perspective and indeed from a nursing perspective, to support us over the last 4 or 5 months. Sharon and Matt were both able to articulate that at the Workforce Committee last week, just the level of hours and the dedication and commitment that those colleagues have provided. And we provided them hopefully with a good experience, which will then hopefully make sure they come to work with us in the near future. The second element I just wanted to pick up is that of training and appraisal. So you can see within the paper, we're now starting to bring back those services, as it were. We obviously turned off incremental progression during the pandemic, but we're putting that back in now as of this month. And so therefore we'd expect to see an uptick in performance in relation to both of those items. But everything else I was going to say for reset, unless there's any questions.
Anything? No. Yes, Tom.
Chair, can I just ask, just in relation to Mark's report, about the vacancy rates decreasing. It seems to be across the board, but at the same time, agency spend, particularly on nurses, from Phil's report seeming to increase. I just wondered about discussion around that particular point, because they seem to be going in slightly different directions, as we might have assumed agency spend might reduce in the context of a better vacancy rate, particularly around our plans to recruit nurses.
Thank you, Tom. And I think that is in relation to still the number of colleagues that we have are absent from the organisation. And whilst there's an absence from a sickness perspective, which is, as you can see, is encouragingly coming down dramatically from where we were earlier, we're also still seeing a number of colleagues in isolation for various reasons, which is causing some of the requirements for agency usage. And also the number of wards that we have open, whilst our bed occupancy is not as high as it usually is many times this year, we are still having to work in sort of a socially distanced way, in different ways, with people taking breaks, etc., with the PPE that they're wearing. So as we move back through our reset, I would anticipate, of course, as our more substantive members of staff come in, then correspondingly our temporary workforce will be leaving us. There's also quite a big piece of work now, as Alan mentioned earlier, in relation to the appointment. There's quite a big piece of work that I need to undertake personally in relation to temporary staffing, and how do we do that across the group, and how do we help make efficiencies based on that. So we know, well, I know anyway, that a number of agency workers that we have working with us in Northampton Hospital have substantive roles in Kettering General, as an example. So how do we prevent that from happening in the future and help the transition from one to the other be easier for colleagues? So there's two elements. There's the one of bringing, well, three, more people coming back to work, less temporary staff in, recruiting more substantive staff, less temporary staff in, and more efficient with our temporary staffing use across the county.
Rachel.
I just want to ask you, Mark, about the sickness absent rate for June at 5.18%. Do we know how that's made up in terms of staff shielding, staff absent for COVID reasons?
Yes, absolutely, Rachel. So it's not made up of colleagues that are shielding, or those that are in, well, so we call shielding national isolation, or those that are in self-isolation due to being exposed to COVID. They are not classified or as sickness absence. They're absent, absolutely, but not sickness absence. And some people are able to still work from home, etc. So the absence figure is truly those colleagues that are absent, i.e. with COVID symptoms, and I'm unable to attend work. However, in the more recent past of this month, we're seeing MSK and stress and anxiety become the two top reasons again for absence. Whilst we were going through the pandemic, obviously it was COVID, but the two that were previously top in relation to absence are coming back, and that's going to be ever so important as to how we look at our health and wellbeing plan moving forward.
Okay, thank
you. Anne.
Yeah, hi Mark. In terms of absence, I know the government today is going to announce an extension to the self-isolation period from 7 to 10 days. I just wondered how that might impact us, and also how are we managing people coming back from holiday that have to go into quarantine? What's our policy on managing that?
Okay, so the first one, as it's not yet confirmed, the only outcome is it will increase because people will be away longer, but it depends on the prevalence of the virus in our organisation or with colleagues in the organisation. So at the moment, thank goodness, it's gone down dramatically from April time, where we had a number of infections, and obviously colleagues that we've seen earlier today in video presentations demonstrate that. We don't have nowhere near that level of staff currently unwell with COVID that we had in April and May of this year. But of course, an increase in isolation when symptoms have occurred would have an impact on our absence rate. In relation to the quarantine, so this has been a hugely popular topic, as you can imagine, since Saturday. Within our organisation, and therefore across the group, the same stance in Kettering is to be taken, which is for those, everybody has to come back and quarantine. The only exception that I'm clear about, the only exception is registered professionals that are coming over to take a role in the NHS, that have a clear letter of an offer letter and a start date. Those colleagues travelling from areas in the exempt zones or in the non-exempt zones are able to commence work and do not have to isolate for 14 days. Those, however, returning from holiday, etc., do until further national guidance is available. So the position across both organisations that we are taking, if an individual or colleague has been, how do we say, caught out on the basis that they are currently away, apologies for that, no. If they are caught out and they were away when that change was made on Saturday, we're making individual circumstances or individual decisions in relation to their circumstances, I should say. If we have colleagues that now knowingly take that risk, then we're asking colleagues to use unpaid leave or annual leave upon their return as part of their isolation. So it's a risk-based approach. I mean, I think I would just re-emphasize, and particularly as we're in a public meeting today, that our advice would still be not to travel abroad, given the global pandemic situation and the unsustainable, the increased prevalence in the virus across the world. But people that do make that choice to travel to a country on that restricted list will be requested to take annual or unpaid leave on return.
Okay, anything else on that? No. Matt.
Thank you, Chair. Again, I would, of course, take the contents of the paper as read, but we'll take just a moment of your time to share three particular points. One is that I am delighted to confirm the appointment of Dr. Toyosi Adeniji as to the post of BAME Clinical Fellow. She's made a fabulous start already, setting up focus groups and developing a program of support and induction for international medical graduates, which is great fillip for the trust. Also to confirm the appointment of Dr. Daniel Sedgwick as a Chief Registrar, and he is working on getting the junior medical staff all onto e-rostering, which will help us to reduce our premium spend on bank and agency doctors, and also is a development that the junior doctors would like very much in terms of giving them some control over their rotas and their balance between their work and personal lives. And alongside that, he's also going to be working together with myself and Mark on reviewing the medical establishment. And again, ultimately, the benefits of that will be through substantive recruitment to an appropriate establishment to reduce dependency on temporary staff and all the associated quality and financial impact that has. And finally, I would just reiterate the outstanding performance of our research team in remaining sort of second in the league chart for the NIHR COVID restart trial and others. Thank you.
John.
Matt, can you give us an update on the VTE situation? I mean, this software company seems to be taking way too long to sort it out. Do we have an alternative? And also, what's the adherence to the paper system in the meantime?
Yeah, very good question, John. And of course, as part of the Governance Light programme that allowed us to focus on dealing with the COVID outbreak that we took through the Quality Committee at the beginning of the pandemic first wave, the Thrombosis Committee was stood down. That has been re-stood up and has met and has come up with a series of interim improvement actions in relation to the paper-based business continuity plan for VTE assessment. I am happy to go into detail here, but mindful of what we have on the agenda, my proposal, as it was requested through the Quality Committee last week, is that I bring back a detailed paper and presentation on thrombosis to next month's Quality Committee.
Okay.
Yeah, thank you.
Okay with that. Simon.
Thanks, Alan. Just to welcome the appointment of the BAME Clinical Fellow. I think this is a hugely important step, particularly in the context of the discussion that we're going to have later on the agenda today. And I'd also just like to note and welcome Liana, who's joined us in the background and who'll be presenting. Liana, you're very welcome and looking forward to hearing what you've got to say. Just linking to the opportunity. So Matt highlighted the research status, and I think earlier on this week, the two medical directors and I had a meeting with the University of Leicester, who are very keen for us to recast our partnership with them in the context of a group And I just wanted to signal to the board that we hope and expect to be bringing back a paper in the next couple of months that sets out our roadmap for how Matt and Andrew will develop that partnership, both in terms of teaching, because there is a hugely significant opportunity to do better teaching, not just medical, but across the AHP professions as well, and also to further extend the work that's done on research.
Thank you, Simon. I'm pretty clear that one of the relatively small number of objectives we will be setting from board for the new organisation will be to do with improved links with primarily Leicester, but also Northampton. Tom, I see your hand.
I presume I would just come in and reiterate Simon's point about very productive conversations between NGH, KGH and the University of Leicester earlier this week. And I think the opportunity is clearly there because of the size of the group model. I think, as Simon emphasised, with 10,000 staff and a very large 2-hospital basis, that provides a very exciting opportunity for both medical and allied health professional education, which will clearly be of benefit to both organisations. And as Matt's highlighted, will allow us an opportunity to build on the excellent clinical research performance with NIHR studies that Northampton and indeed Kettering both enjoy. So we very much look forward to it as a university organisation too.
As my son frequently says to me, it's great when a plan starts to come together, Dad. And that seems to be one. Anybody else on that? No. I too welcome the BAME Clinical Fellow. I was enthusiastic about that when you first raised it with me a month or so ago, Matt, and I'm glad to see that's come to fruition. And I'd like to meet the lady in due course, maybe when she's been in the job for a bit. And I'm also pleased about the appointment of the Chief Registrar. We might just log the possibility that we ask him to come along to a board and talk about issues with junior medical staff later in the year when he's been doing it for a while. It's an area where, you know, things have been done, but perhaps we haven't got it right in the past, and it will be, it's an important role from the hospital point of view, which hasn't been there before. Okay, anything else on that? No. Okay, I think we're there. Board Assurance Framework, Claire, on you go.
Thank you, Chair. The board will be aware that you had a copy of this last month, which was basically the reset document. This month is the overarching review of the document, where all executives have been through this and some of the risk titles have been updated and simplified. And all the corporate risk references have also been updated. The risk 1.3 about sequins has actually been removed for the total of the rest of this year because the scheme has been suspended. Other changes are that we have added a further COVID risk 1.10, which is about the risk of the trust being unable to deliver a recovery plan post-COVID. So that has now been put onto the BAF with a score of 20. And the only other part I'd like to highlight to you is risk 5.3, which is about the capital programme. So despite the good news earlier regarding ITU and the electrical infrastructure, we still have some outstanding capital, which regarding to COVID related spend on capital, which remains outstanding and the outcome unknown. So that risk has been increased from 20 to 25 to reflect the additional gap. I'm happy to take any questions on the document.
And I think everybody, yes, Jill.
Thank you, Chair. It was a very small comment, actually. On page 51, we've got some controls in relation to the risk. And one of the things that's mentioned is the board to ward visits, which have been suspended. Mm-hmm. I wonder, very, very difficult to decide when we recommence them and how, but I think they're so important. Is that something that's been given consideration?
It is, and it's something that Sharon and I will continue to discuss and look at different ways we can do that, even if it is, you know, in some virtual form or some data forms instead of actually visiting. But I'm sure there is something we can do.
David.
This was something I mentioned at Finance yesterday. It was just about the target risks for 1.7 and for 1.8 being the risk of failure, the states and the risk of failure to ICT technology, basically, and how we get from our current scores of 20 to a score of 10 and 10 is really not articulated in the board assurance framework document. Now, another minor point is I thought each of these risks had 2 pages originally. They only have 1 at the moment, so 1 is missing. Correct, Claire?
No, the whole document is there now.
This was the whole document, wasn't it?
Yes, it is the whole document.
So that was my point. How do we achieve the target scores for those two risks? It's not well articulated as I read these anyway.
Okay, thank you. And we did pick that up yesterday, as you say.
Yeah.
I haven't progressed that further, clearly because of the timing, and it's something that I will be discussing with both Stuart and Debbie and the appropriate people before the next iteration. So we'll come back with some further detail for you.
Thank you, Chair.
Okay, all done. Yeah. Okay, COVID reset plan. There's an awful lot in this. There's a bit about our expectations. There's a bit about the flows from the first 2 vlogs today about what we need to really, really raise our game on here in the best possible way. And it's a comprehensive approach. When we started talking about this a couple of months ago, board members were clear we needed a plan which was coherent with Kettering. And they're not the same plan necessarily, but they did have to be coherent with Kettering and at a more strategic level, 1 plan. So thinking about the immediate issues, but also thinking about the opportunities that fall out of, again, beginning to be a group. And the capital is important, but it's not going to happen overnight, and that will take money to spend. Board members can take some credit from being brave enough to commit money before we had it from central government to make sure we were ahead of the game there. And it's always reassuring when we find we made the right decision, or you made the right decision in that regard. But this is a comprehensive plan and is arguably the major item on the paper in terms of the way we run the hospital today. There are other major items around strategy and culture, obviously. So I believe this is led by you, Debbie.
Thank you. It's going to be a joint effort, actually, from Chris, myself, and Mark. We have got a presentation to give you because I'm conscious that there's an awful lot of information in the paper that we've given you in your packs. So could we have the presentation up, please? Thank you. And I'm going to hand over to Chris to make a start.
Thank you very much. So next slide, please, Kieran. So at the end of April, Sir Simon Stevens set out the 2nd phase of the response to COVID. And in one of the appendices to the main report in the pack is the response that we made at Northampton alongside our colleagues at Kettering. And you can see the details within that. That phase of the recovery requested the NHS to step up our non-COVID urgent services as soon as possible, and of course required that reset to be done in a way that was safe and COVID secure. I overall lead the reset programme and are strongly supported by all of my colleagues. And the way that we've managed that is through the silver calls, which take place every day, and 2 each week are dedicated to reset, led by the silver commander and attended by all of the clinical and operational lead within each of the cells that's listed in the pack. As we move into month 4 and anticipation of the next phase of reset, we've taken stock of the current position and we've reset our priorities going forward. And this presentation takes you through some of the highlights from within the main report. We have reset our urgent treatments, our screening services, cancer diagnostics, and are undertaking some routine outpatients and direct access and elective treatments, but you will see that we have some way to go on our elective and day case procedures. Cancer diagnostics and treatments clearly will take priority over our routine patients, but nevertheless, as we've heard very strongly from our patient vlog earlier today, we absolutely must focus on all of those that we serve. And it's also important to point out that through the pandemic, we were able to rapidly adopt new technologies across many areas of operation in outpatients, through some of the monitoring of our oxygen services, and also through remote monitoring that have really assisted, in particular for outpatients, enabled us to maintain 80% of pre-COVID activity. Thank you, Kieran. Some more specifics. From an elective and day case position, our overall waiting list is now just under 5,000 patients, which is made predominantly of day case patients, 3,500, about 75% of that waiting list. The waiting list itself had decreased to 2,345 at the end of April, as we clearly were treating some patients, but mainly were validating that waiting list against those patients which still required their treatment. From where we currently are now, our elective activity is at 35% of pre-COVID levels, and that is underneath that which is being reported regionally, which is 44%. And our day case activity is also at the same percentage level compared to 41% regionally. Overall, waiting times, as expected, have increased and are currently averaging 17 weeks. Throughout the pandemic, 449 of our patients had their urgent surgery undertaken at BMI 3 Shires Hospital across the road from ourselves. Those were predominantly cancer and very urgent patients who we were able to proceed with their treatment in a COVID secure environment. 310 patients have waited over 52 weeks. 44 of those are awaiting diagnostics, 34 outpatients, and 221 are awaiting admission. But more importantly, what are we doing next? So currently all category 1 who are urgent patients are treated at the 3 Shires Hospital, with some capacity also at for category 2 and 3 patients, and that is now undertaken during the pandemic at 3 Shires and now being undertaken on both sites. 2 theatres have reopened in our main theatre suite, plus gynecology theatres for elective operating, which we will now repatriate from 3 Shires. And in place, we wish to, and we are moving our orthopaedic operation across to 3 Shires, so that is completely COVID secure. From an elective perspective, we had designated Althorpe Ward as our green surgical bubble to enable us to carry on operating on urgent patients at NGH in a completely COVID secure environment. But we'll now just take you on to a much more detailed view on cancer, and I'll hand back to Debbie.
Thank you. So just to give you an update really on where we are with regards to cancer, and this is the main focus, as I said earlier, for me over the next few months. This is our performance over the last 4 months. If you recall, our cancer performance is reported in arrears, so we won't get the most up-to-date information. However, saying that, 62-day performance has now started to increase as our backlog decreases. So that's just to give you an overview to start with of our performance. So if we could have the next slide, please. There's more information in your pack, but I would like to highlight specifically where we are with some of our cancer weights. So this slide shows you the numbers of patients on our cancer list. We call our cancer list a PTL, so I may refer to that as a PTL. These are patients that have already been referred into us. And it's split by those that are diagnosed and those that are undiagnosed. And as you can see here, the majority of our patients are not diagnosed yet. I would just like to remind the board that during the pandemic, the numbers of 2-week wait referrals received in had reduced. I haven't got that information here on the presentation, but that is in your pack. If you want to refer to that information, it's on page 90, and you can see a dip. There's quite a significant dip in the 2-week wait referrals. If you also recall, at the start of the pandemic, all providers were told to pause high volume diagnostics. So diagnostics such as endoscopy, for example, and they were paused due to the serious risk of spread of infection. I'm pleased to say that surgery for our cancer patients and also chemotherapy was transferred across to the BMI 3 Shires and was delivered there, and has continued to be delivered over there. Could I have the next slide, please? So this slide tells you, it shows you the patients who are on the cancer list on the PTL and those that are over 62 days. And it splits down by those who are diagnosed and those who are not diagnosed. And as you can see, we've got 117 in total, but only 21 of those patients diagnosed at the moment. 96 of those patients are not yet diagnosed, which of course is a large percentage. And as you can see, the majority of those are waiting for a diagnostic test, such as endoscopy or colonoscopy, for example, which I just said earlier with the areas that were paused. They have restarted now, and I'll come on to talk about that. So we have got additional endoscopy capacity in place. We've got 12 lists in place each week. That means that we are operating across 7 days at the moment as well. But what I must say is we are not doing the same number that we did pre-COVID, and that's because we've got less patients on every single list that we've got in place at the moment. We need to have some downtime between patients, and we also need more time now to make sure that our consultants and nurses who are performing these diagnostics are using the right PPE. Of course, we know that when you put PPE on and you take it off, that takes quite a lot of time. There's an awful lot more process in between each patient. So of course, we can't get as many patients onto the list. So we're estimating that by mid-November, the total backlog for routine patients will be cleared. Could I have the next slide, please? Thank you. This just gives you a little bit more information on endoscopy. We are also expecting that within the next 5 weeks, we will have cleared every single patient who is waiting for an endoscopy for cancer. So the endoscopy information on there does include all the routine work that we need to do as well. It's not just cancer. Each tumour site has got a recovery plan in place, and within that recovery plan, they have a trajectory. As Chris alluded to earlier, we have reset meetings in place, and those plans are currently being signed off, presented to and signed off at the reset meetings by Chris, myself, the medical director and nurse director. I think the only other thing that I really want to say on here is, as I noted earlier, this is a priority for me and the organisation over the next few months. I will dedicate the majority of my time to making sure that we not only meet the performance, but we are getting these patients in and diagnosed and treated as quickly as we possibly can. One of the questions that you may have on cancer is what happens to those patients who have been on the cancer list a long time and perhaps may have come to some harm while they've been waiting. I'd just like to pass over to Matt, if I may, our medical director, just to talk about harm reviews that we have in place.
Thank you, Debbie. So briefly, prior to COVID, we had already established a process for reviewing patients who waited a long time for their cancer treatment, so specifically greater than 62 days, and then further enhanced process of review for patients who waited more than 104 days, which is in line with the sort of national milestones of delayed cancer treatment. The process involves both the hospital's cancer services team and individual cancer type multidisciplinary team leads and the governance team reporting to Claire, all collectively reviewing and breach mapping those long waiting patients to look for causes of avoidable delay. And pre-COVID, the majority would be due to either highly complex diagnostic pathways or patient choice, but we were always looking for opportunities to streamline our pathways and improve performance and experience for patients. As part of the governance light that I mentioned earlier when talking to John about thrombosis, we had stood that harm review process down and concentrated on getting those patients treated, but we have now stood those harm reviews back up. And I suppose a key question when we are doing the reviews of long waiting cancer patients will be whether or not the delay was avoidable in the context of COVID. Thank you.
Thanks, Matt. I'd just like to end the small part on cancer just by, I think, I'd like the board to acknowledge the main challenges with regards to cancer. So one is the endoscopy capacity, and we know that we will have to work across the region to make sure we've got enough endoscopy capacity in place. That for us will inevitably mean that we will need some capital investment for endoscopy. And I think the other challenge here is making sure that we have a surgical area that is what we are calling completely green, and we don't introduce infection at all into this area. Now, this does sound quite simple, but it's a massive challenge in itself, working in an organisation where we do still have, not many, but we do still have some COVID positive patients. We do not want that, that virus moving around the organisation. So we do have a ward that we have designated as green. That has opened and continues to be green. It's tricky, but we are really focused on making sure that all of our procedures are well established, in place, and the staff are fully aware of the use of PPE and maintaining infection prevention procedures properly. So they're the two challenges, I think, moving forward. And of course, we will now be planning also for COVID-2, which will be expected along with winter pressures. So again, making sure that we have enough capacity to not only treat the cancer patients, but also the emergency patients that will be coming in through COVID-2 and winter. I'll hand over now to Mark to talk about our people. Thank you.
Thank you, Debbie. And I'd just like to start this presentation reminding us all about what we saw at the beginning of today's meeting in relation to Brian's story particularly, and how this has been such a difficult time for colleagues. I could, in a multitude of ways, and I could wax lyrical about this literally all morning, and I won't because Alan's got a meeting to chair, but I mean, the way that colleagues have been able to perform their duties over this period of time has been nothing short of outstanding, and that comes back to my team too, in terms of setting up testing centres at the drop of a hat and so on and so forth. It's, you know, it's fantastic. So if I can go into the next slide, please. So one of the things that we've been working on quite heavily over the last few months is in relation to how we ensure that we protect our staff, and particularly those staff from our BAME community. And there's a presentation on an agenda item very shortly in relation to that. But essentially, we've had various guidance and information in relation to risk assessments, and we are now in a position across the whole organisation of conducting a welfare risk assessment for everybody. We have and did focus our attention firstly on those who were categorised as a vulnerable group. So those people with underlying health conditions, or as we latterly found out from a BAME background, due to the disproportionate effect that COVID-19 was having on colleagues from that particular background. And as you can see here, we at the time of writing the report, we'd conducted just shy of 2,000 welfare risk assessments for BAME colleagues and those who are vulnerable, and we have met the needs of those individuals. So we've looked at the mitigations that we could put in place, and that has been varied. So we have seen some colleagues that have come forward with underlying health conditions, and I'll go on to that in a later presentation as to what those conditions have been. We have seen concerns from colleagues, particularly in relation to the application of PPE, and all sorts of I wouldn't say confusion, but just uncertainty around the levels of PPE, and people moving from one area to another, and somebody wearing a slightly different mask than someone else. What is that reason? What's been that rationale for that? And there always has been good reason, but clearly in times of uncertainty, we just need to make sure we have those conversations with colleagues. And what really struck me earlier in Brian's conversation is also been something that we found out in the welfare risk assessments too, which is not just the impact on the individual in relation to COVID-19, but the impact on their families. And we've put a number of provisions in place, which is in one of the appendix of the pack that Debbie's referred to, in relation to health and wellbeing activities, and particularly in relation to our SOS team, our supporting our staff team, which I'll come on to shortly. If I could take the next slide, please. So in terms of our reset plan, our cell around staff and colleagues, as you can see, it is huge. There is lots of work that needs to be undertaken, and all of that is articulated in this one slide in terms of the skeleton as to what that looks like. How do we continue to maximise our staffing levels and enable attendance in the organisation? How do we support alternatives? How do we source colleagues from a number of different areas? And that's based on ever-changing guidance. So again, as we was talking earlier in the integrated performance report section, guidance has changed 2 or 3 times this week in relation to some of those areas, and we need to be responsive to that, and making sure we're helping to support our staff and colleagues. In terms of staff wellbeing, as I say, this is a real big focus of our attention at the moment. If I was just to take shielding colleagues alone at the moment, we have 156 colleagues who have been shielding in our hospital. Who are under, well, who have received guidance obviously from the 1st of August that they can stop their shielding position. But this is a huge time of concern and anxiety for those colleagues, and how we're helping to integrate and support them back into the workplace has really been a main focus of our attention over the last couple of weeks. We've held a number of listening events. We've held a number of events where colleagues can come back on site, many of which have been, well, all of which have been for the first time in 4 to 5 months. And honestly, some of the stories that I hear personally about some of this work that colleagues are undertaking, we can't underestimate the challenges that this provides to people in terms of these colleagues have been asked to stay at home and not move, and some have not, and absolutely have not for a long period of time. So even coming outside the front door is a real challenge for some of these colleagues. And then we have the situation in bringing colleagues back into the workplace. We articulate it in our team as people with different badges, and how do we incorporate and bring a workforce back to being a cohesive team in relation to that, because you have people that have been here during the pandemic, you have people that have not been here during the pandemic. Many things have changed in the organisation in the hospital since the pandemic commenced, and what does that look like and how are things different? It's almost a reintroduction or reinduction for colleagues back into the workplace. There are a number of other elements that we look at quite frequently, as you can see, and we've been hugely benefited by a number of kind donations during that period of time in terms of a food provision, car parking, etc. How do we make it easy or easier for colleagues to attend work? And that's really important. The creation of the Our Space, which is now hosted in the boardroom, and those real sensitive conversations with colleagues. And we also have the element of volunteers. So we've had a huge number of colleagues that have come forward to help volunteer over this period of time, and how do we use that to our best benefit? You know, you've seen some of the fantastic work that colleagues have been able to undertake in terms of supporting patients. Again, Brian mentioned earlier the difficulty that he and his family had in the not being able to visit perspective, and we've been able to utilise our volunteers and technology to enable to support that, so people can see their families, and that's predominantly been run by a volunteer service, which deserve a huge shout out. If I could take the next slide, please. So what are our plans, and what is it we are working on? So the first one is, as I say, is to improve our attendance. So how do we help support people back into the workplace, and how do we help in terms of the next item to keep as many people in the workplace as possible? So i.e. if we see any transmission of the virus, which obviously, as Simon articulated earlier in the board meeting, is still prevalent in our county, how do we make sure we work upon that to make sure that people can stay at work, so colleagues can stay at work in order to support our patients. So we've been lots of conversations. Obviously, the introduction of masks within the organisation in the last month has been huge as a part of that. Now, I think it's fair to say compliance is high, but it's not 100%, and we have to keep a focus on that in terms of reminding colleagues to be compliant in wearing masks in and around the organisation, and just continuing to work on areas of hotspots, so where we see or can see transmission of the virus, or indeed see the virus anywhere. How do we help and support colleagues? How do we give them the right advice to isolate correctly, etc.? And how do we continue to support those colleagues working from home? We have seen huge benefits in terms of that as we've gone through the pandemic. How do we continue to help people with that? How do we mix and blend that? How do we not just go back to what we did before? How do we utilize the benefits of this terrible pandemic and the lessons that we've learned from it in colleagues working more remotely and being able to do different things, and therefore that having an effect on our estate and our future plans. If I could take the next slide, please. And one of the strongest elements that's absolutely come through during this pandemic, again referring back to Brian's conversation right at the top of the meeting, one of the innovations and the things we've been able to expand upon is supporting our staff, and how we do that in terms of different conversations with people, or having conversations with people about what support they might wish to utilise or to undertake. We know, as an example, that we certainly know, and we'll never forget, that we've lost 2 colleagues during this pandemic, and in both of those areas we've been able to be around and supporting colleagues, give them options and avenues and advice to have conversations. And I think it's fair to say that some of the categories of colleagues in those areas would not normally be the people that would feel comfortable in speaking about their feelings and how they are, and seeking that support. And so we've been able to do that in a multitude of ways, whether it's in group sessions, one-to-one sessions, etc. But it's been ever so important, and honestly this team led by Vicky has been fantastic in supporting so many colleagues from really difficult places, particularly with their mental health. And we're also looking at leadership. So we've had leadership for a really tough, difficult time. How do we look at supporting that even further? And that's something that I'm proud to say we've been able to do as part of the group. So we have, in conjunction with Kettering, been able to work on a program called Leading the Way. And so how we've been able to provide a series of virtual webinars, seminars, and some virtual tools to help colleagues lead, not just through the pandemic, but post the pandemic, which in my own humble personal opinion has been even more tricky than during the initial outset of the pandemic, in terms of trying to balance so many priorities in continuing to manage the virus, whilst also trying to make sure we look after those patients and service users that are not affected by the virus. And of course, we're continuing to support the reset program, which has been articulated, and that includes all sorts of things such as antibody testing, which we've rolled out across the whole organisation, and the continuing to support the test and track, or test and trace program nationally. We still do offer tests for those colleagues that are symptomatic. Within literally hours of them confirming they have symptoms, we can bring them into the organisation and get tested and get a result confirmed within the day. And how we support those conversations, particularly in relation to colleagues returning to work, acknowledging the fears and anxieties of some colleagues, and maybe not too strong a word, some resentment from other colleagues about people that haven't been here during that pandemic, and understanding the complexities in those relationships. So that was all I wanted to say on this. Thank you very much.
Okay. Thank you for that. Can I just say, I'm very conscious of the fact that Debbie's talked about the cancer issue as being a major priority for her, but in our conversations we've had about developing the group strategy, it's also clear that achieving the cancer target, and better than the national cancer target, is going to be the second one I mentioned today of what is likely to be a very small number of priorities. And I also recognise the point Debbie made, that if the board makes these things their priorities, they ought to really put some time and effort into helping to deliver them. So to that end, I've asked Rachel and Tom to be the 2 non-exec directors, bringing both their particular perspectives to bear to help with particularly the cancer element of the research. Now, I know this will be handled through the Quality Governance Committee as well, Tom, and I know other committees will look at this, but nevertheless, I think it's important that we have a strong non-exec director link with that particular bit of work. And I'm very happy, obviously, if those non-execs, or indeed any other NEDs, wish to get involved in other aspects of the reset programme. But there's a clear recognition of the board's emerging decision that being better than the cancer target nationally should be what we aim for. That's what we want to do on that. So Tom, you had your hand up.
Yeah, I think you've touched on it slightly, Chair. I mean, clearly the cancer target is going to be a focus of the board, and indeed is clearly a focus of the Quality Governance Committee. We probably spent over half of our meeting last week hearing and discussing a presentation by the cancer lead from the Trust, with input from both the Managing Director and the Medical Director. I think we were reassured that there is a clear plan which prioritises this area. I think another positive thing was there's significant amount of regional learning, and it is clear that different hospitals are at different stages in the pathway, and particularly at different stages with respect to different cancer sites. So there is an opportunity to learn and put in place best regional practice. And we've invited the cancer lead back to the Quality Governance Committee in September, so that we really have an opportunity to see that we're demonstrating clear progress against the targets within the plan. Probably just to highlight three other things, and just to reinforce what Debbie said about imaging and endoscopy capacity, that really is an absolute must that the board really needs to support to ensure that we have every opportunity to meet those targets. That probably, as you've touched on, may be a benefit of the group model because of the priority around IT and imaging infrastructure and investment, because that clearly will be important in delivering not just the targets in Northampton, but across the group. And I'm sure Simon would support that. And then I think finally, just one point to ask, which probably didn't come across, is clearly in delivering the cancer targets, we're for some sites affected by partner organisations, particularly for tertiary centres. And I presume I'd just perhaps invite a comment either from the Medical Director or the Managing Director just on our interactions with our partner organisations, and just being reassured we're getting the support that we need for our patients where we're relying on other organisations to deliver target.
Yeah.
Okay, thank you for that, Tom. Debbie.
Thank you. So yeah, you're absolutely right, Tom. So one of the patients on our cancer list at the moment that's been waiting the longest is waiting for an operation at Leicester, which is one of our tertiary partners. We are in conversation with Leicester every day, but like many others, they are also struggling with capacity. But what we do is go out to other organisations. So we've been working with organisations within the Midlands as well as the East of England. But yes, you're absolutely right. This is it's a regional challenge. We're in discussion, and we are escalating to the highest level if we're not getting anywhere.
Rachel. Happens to everybody. Still muted, I think.
Got it. Mouse stopped working. Just to say that really welcome the opportunity to support Debbie and the team in the progress we make on cancer. Just a question maybe for Debbie is, do you know how long we will have the woodlands for? And really what use we could, not woodlands, sorry, the 3 shires. And my second question was, are we able to exploit the woodlands as a place to deliver care?
Yeah, thank you. So Kettering, I believe, are working with the woodlands at the moment. We are working with 3 shires and also the Horton at Banbury. We are continuing to work with them until the end of the financial year. And I expect that will need to go into next year as well, next financial year as well. But we are one of the best users of the private sector within the region, which is really good news. Our numbers over at the 3 shires last month decreased slightly. We need to make sure that we're increasing those again. But what we did see last month was quite a few people starting to take some annual leave after the intensity of the COVID few months. So I feel assured that number will start to increase again over at 3 shires. But yes, it's needed.
Have we found that, I think one of the things we spoke about last month was trying to encourage people to come and attend their appointments. Have we had an uptake, an increase in that?
Yeah, it's still a problem, but it's better. Definitely, I haven't got the numbers in front of me, Rachel, but it seems much better. And especially, I think our challenge going into the next few weeks will be the fact that the government has said that for elective patients, they now don't need to self-isolate for 14 days. We are really conscious of that, and at the moment it's being discussed within the infection prevention work, but we are really reluctant to relax that period for our patients. Matt may want to comment on that from a medical perspective, but our consultant body at the moment want to try and continue with our patients having that self-isolation period.
Thank you.
I think too, we've always got to think about this in the context of Northampton's rates of infection and illness. We might reasonably assume most of our staff live in and around Northampton, so that becomes a genuine issue, particularly with the rate of asymptomatic testing. And that takes us to the business of giving our patients confidence that we have these absolutely secure green areas, and we've talked about that already today, so I'm not going to repeat that. Anybody else commenting? Matt, do you have anything to say on that?
Largely just to echo what Debbie was saying. I think it's we've had a discussion with our divisional directors, particularly those that manage surgical specialities, only this week in relation to the recently relaxed guidance in relation to preoperative isolation issued by NICE and others, and there is an innate and probably very sensible caution around that from our senior surgical leaders, despite the fact that many of their troops are champing at the bit to get back to doing more operating and would like to see it relaxed. And I think that's because we know just what a infectious and virulent disease COVID is and the terrible consequences it has. We've heard Brian's story. What you won't know, but I know that he won't mind me sharing, is that he was shielding at home with meticulous care and attention for 5 weeks before he contracted COVID. So setting up these ultra green COVID safe areas is will never be a perfect science, and getting the balance right. There's no rule book for this, but we are taking a very cautious approach because of the consequences of perioperative COVID acquisition in terms of morbidity and mortality.
Okay, Jill and then Simon.
Thank you, Chair. One's a question and one's a comment. The comment is around mandatory training, which we again discussed in quality governance. I mean, the training is obviously important, or it wouldn't be mandatory. And I welcome the opportunity to review that, particularly across Kettering and Northampton, to streamline it and potentially make it shorter and more useful for all levels of staff. So mandatory training doesn't impinge so much on clinical time. And I know that's a very fine balancing act, but welcome that opportunity has presented itself. The question is in relation to cadet nursing. So in terms of recruitment, is that one of the pipelines that we can begin to pursue, or is it too early to do that yet? Because I'm conscious we still do need to have a massive recruitment drive across all fronts, but particularly nursing.
Jill, that is something that we've started to think about, and it is forming part of our talent academy that we already have in train.
Okay. Okay, Jill. Where did I go now? Simon.
Thanks, Alan. So I think this is a really important presentation. And I've got 3 comments and then a suggestion for the board. So I want to be clear. I think today's presentation sets out the challenges that the organisation faces, but I don't think yet it gives clear resolution to the fact that these challenges can be addressed and met. Something that the presentation didn't touch on, but I just want to remind people to look at is the slide on diagnostics in the main pack. It points out that not only is there a backlog, but there's also a structural imbalance in terms of demand and capacity across the organisation, across some of its key diagnostic modalities. That should and will continue to be a cause for concern. If you can't run the run rate through the machine at the rate at which you need to, it's going to lead to delays in people getting the treatment that they need. The second is the cancer position. I think the presentation speaks for itself, but there is a real need to describe to the board and to our public how we're going to recover that position and start to move towards meeting our aspiration. I'd simply point out here that the problems that have been seen in COVID are not just COVID. There was a structural problem about cancer under delivery prior to COVID that in many respects has probably has been mitigated, or the performance has been ameliorated by the fact fewer people have been moving through the system. And then the third problem I'd like to highlight is in terms of elective and day casework, the 52-week breach position. You will have noticed if you read your slides, between the slides and the presentation, has continued to worsen. So I don't want to underestimate the size of the challenge that is now in front of the organisation in terms of getting back on track. The only other thing I'd say on day cases, it's right, and the relaxation on isolation requirements has been reduced this week, I think. There's going to be a balance of risk, isn't there? We know that one factor that has been the significant drop-off in terms of elective activity is people have said, frankly, people have voted with their feet. I'm not up for isolating myself for 14 days in order to get my treatment. Now, there are consequences to that, and we need to balance the risks of managing COVID with the risks of people walking away from treatment that they need. And that is a very delicate and difficult balance, but one I would like the committees as they go through the September cycle to look at, which finally leads me to my suggestion. I think in September's board, my suggestion, Alan, would be that there are kind of 3 linked presentations that look at, firstly, the diagnostic issue, because there are important, both immediate as well as deeper structural problems. Second, the elective and day case issues that we've just been discussing. And then thirdly, the cancer, but with a view to making some statements about, so how and when is this going to be recovered? Because what we've done today is to set out in many respects the size of the challenge. And I now think we need to come back through the September committee cycle and say, okay, how do we respond?
I'm getting a lot of nods of approval to that structured and coherent approach. Anybody else want to say anything about this whole reset plan? Tremaine.
I just think, firstly, it's clear that we've arrived to the challenge in a lot of ways, and the detail in the presentation indicates quite the task ahead. I think that the challenge I'd sort of present to everyone is around looking. One of the things I saw that isn't mentioned yet, and is potentially part of how Simon's challenge around responding, is how technology can play a part in helping us with some of these challenges. So with moving forward to being a digital focused organisation, I know looking at interestingly looking at some of the innovations happening in trusts around the country. There's certain things around triage and the vast quantity of data we're now getting from patients in the community and trying to manage the outpatient side, just not to sort of challenge to try and be innovative where possible and look for think outside the box, because I think this is a challenge that to be realistic, we haven't faced this challenge before with COVID, so the solutions are going to be different, so it's just a challenge to everyone on that.
Challenge received, Tremaine, and clearly the work in outpatients is good, but you know, everything can be better, and there are plenty of other things. I've spoken to, I live in the other end of the county, so I you know, I don't speak to that many patients who come into Northampton, but I've spoken to a couple recently who have been pretty complimentary. One in particular about the orthopaedic service and how that's happened, and it's been virtual appointments and then face-to-face and very coherent approach, taking advantage of technology and then moving to a secure kind of face-to-face. I've heard from others who've talked about the slight randomness of telephone calls for virtual appointments. And I know from another hospital, my own experiences, they don't tend to call you when they said they will. And that's quite difficult to cope with if you've got another bit of your life. And I think too, there are issues around how hospitals do this. Hospital phone calls, for most of us will know, come up as number withheld. And most people, that's an alarm call. They don't take that, receive that phone call. And so we are going to have to think about this rather carefully. We're either going to have to get the timing dead right on these appointment phone calls, or we're going to have to find a way of showing who it is or what it is that are coming up. So there's some technical issues and challenges in there, however much we might want to do it. So fair points, Tremaine. Denise.
Yeah, I mean, I think my first point, actually, Tremaine started covering it, and it was just about thinking, moving forward, thinking inevitably, coming back to something that Simon said at one of the meetings last week about we need to be brave and you know, sort of think outside the box moving forward. And these are big problems. So I guess it's sort of if we try to deal with things in the way that we've always dealt with it, then that's not necessarily going to get us where we want to be. I did also have a query that again might be included in the point that Simon made about some of the sort of specifics in terms of how this is going to be recovered. But Debbie, you when you were talking about endoscopy capacity, you said in particular looking for the board because capital is required for this. So just on that point in particular, what are the next steps in terms of that?
Yeah, that's a good point. Thanks, Denise. So what we've got a list of capital requirements at the moment. We've obviously been given the large amount of capital for ITU and the electrical infrastructure. But out with that, we've got a list of about 1.5 million of other things that are needed. We have agreed that we need to prioritise that list and also look at what we are currently have in place as planned with our capital for the remainder of the year. And that will be across medical equipment, IT and estate. And we have a meeting in the diary for Tuesday next week with our senior clinical leaders to go through that and start to prioritise. Those requests for capital are all with the centre at the moment. And we are waiting for a response back.
Oh, Stuart.
Just to add to that, we're not letting the grass grow beneath our feet, so we have gone ahead with designs. The majority of the capital cost in endoscopy is around the air handling equipment. So we are going ahead designing it in the meantime. So if we do get the nod to go ahead, we're ready to go out to tender.
Okay, and when Simon talked about going through the committee cycle, I mean, what that really means is that the finance committee, the workforce committee, the quality governance committee, all spend time looking hard at the their issues within those 3 areas that Simon talked about to come back into a September cycle. Now, you know, you're perfectly willing to take those forward in the August committee cycle as well. I expect there's some issues you'll want more than one bite at the cherry on. And assuming we agree the collaborative group governance program committee, then I'd expect that committee to be looking at what it can do for those areas as well. And so that's a complete focus through the committee and board cycle into the September public board meeting, so we can tell our public in both hospitals, particularly, but in Northampton in this case, exactly what we plan to do about this and when we plan to resolve it. Okay, I think we're kind of there on that. I'm conscious that we're running a little bit behind, and I'm conscious of our colleagues for the other item, but I think we can go pretty quickly on the improvement plan, which is fundamentally just an update of where we are. Claire?
Thank you, Chair. You won't have seen this since January, February of this year. So because of COVID, this was suspended. It was reset last month. You will see that there are a number of actions have been closed since that period of time, 34 actions. Good progress is being made. All the must-dos were delivered really quickly, the actions in relation to them. So it's just the should-dos that remain outstanding. The one thing I did want to just draw the board's attention to, clearly CQC is an ongoing review methodology. So our next inspection will be due towards the end of this calendar year. We don't know for definite clearly when. We will need some additional board prep for that, specifically for board members who've not previously been involved. We'll also need some help. And also regarding the well-led aspects. I just wanted to draw the board's attention to that. So we will get some dates in the diary for some more information.
We'll be talking about some of those issues through development sessions, but handling the issues raised by CQC is not an exercise in getting ready for the next inspection. It's an exercise in making things better on a permanent basis. So that's what we'll be working on. But I think Claire's point is more about we've got some new non-exec directors, and it's right and proper that we explain to them clearly what the process is and make sure everybody is up to date. Okay, everybody happy with that? Yes, thank you very much. And the group governance paper, again, fairly self-evident. I know we've talked about this before in a workshop session. Boards were keen to ensure that that this work was taken forward in a coherent group basis, and we have a vehicle to do it here. Do you have any comments or any thoughts about it before we say yes to that? Claire.
I just wanted to add, Chair, that today we're actually approving the terms of reference, which is a mirror document going to Kettering's board tomorrow as well. But also to approve the fact that we will have two NEDs co-chairing, one from Northampton and one from Kettering, who will alternate, and Rachel is the proposed non-executive from Northampton General. Yeah, and I mean, it kind of goes without saying that the chairman can come to any of these committees, but if you feel we need to stick it in the terms of reference of membership, you might want to do that as an ex officio member. Any other comments on the membership or nature of the committee or the role and responsibilities? We'll be up for review. Anne.
Yeah, just on the membership, are there going to be any other NEDs on that committee? Because if Alice and Rachel are co-chairing, that's just two. Do you need any other NEDs on that? Because it's the exec team, isn't it, members? And
yes, well, I think that's up to the board really, if you feel that's appropriate.
Oh, it was just a observation, that was all.
I think that it is an important committee, and it's a full board committee. There are complications in that, particularly when you link with a foundation trust, but it is a full board committee. I'm very open to the idea of having an additional non-exec from each organisation attending or being on that particular committee. And I recognise that it is an overwhelmingly exec committee in its current form, apart from the two chairs, both of whom are no doubt extremely competent at handling that. I'll leave that thought. I'm not seeing any great reaction. I'll leave that thought, and we'll maybe talk about it in a non-exec group, because there's a complication here. You're absolutely right to raise this question, Anne, but there's a complication here in that we are increasing the demand on non-exec directors as part of the group model. Meetings may end up being a bit longer. There will be other things to be done, and we're also talking in the healthcare partnership about system committees, system finance committee, and we have a people board which is mostly executive within the system, but we're also talking about a quality. But those are not resolved yet, but all of that is extra burdens on non-exec directors. So I think we just have to try and manage the two. It may be an exercise in experience to see what it feels like for our two non-execs to be in an executive lion's den all on their own. But it may be that there is other non-execs who'd like to talk to me about their interest in this particular bit of work. So we'll take that forward in a different way. Thank you very much for that. Okay, sorry for the delay. I think I'm now 10 minutes late, and we're on strategy and culture, equality, diversity, inclusion, BAME staff support. I'd like to welcome Tim and Liana, who, if she cares to bring her video up, she will appear. There you go. Technology is wonderful. And I presume Mark, where is he? Mark will be introducing this as we start to go through one of the major strategy, well, the major strategy and culture issue of the moment. On you go, Mark.
Thank you, Chair. So yes, and thank you, and welcome Tim and Liana to your first public board meeting. So there's a paper which everybody has within the fullness of the papers in relation to our equality, diversity and inclusion annual report for 2019-20 and where we've got to. And we're just producing a presentation today in relation to try and make that a bit more user friendly for the public and for colleagues to present to. But there are clearly challenges in relation to diversity and inclusion within our organisation, as the report highlights. Whilst we are starting to take some small steps in addressing those, there is still a great amount of work still to be done. And we also then have the impact of COVID, which has obviously been a large section of our agenda today, and some national reports that we've received in relation to some reviews conducted by Public Health England and Department of Health, and the impact that COVID has had, particularly on our BAME workforce, and what is it we can do about that. But it also, if nothing else, it just reflects the inequalities that exist both within our organisation, let's be open and honest about it, and across the nation wider. And of course, national events, international events have also taken quite a lot of precedence in the recent past. So in terms of the presentation today, and just opening the presentation, I just want to go back and talk a little bit about where we are and what the information tells us about us as an organisation. And then I'm going to come on to introduce Tim, who's going to talk through our workforce race equality standards position at the moment in our organisation, and a fantastic infographic he and the communications team have worked through. But that's all great, and that gives us a position statement. But what is it we're going to do about it? So then Liana's going to talk to us a little bit about our BAME network, who's celebrating their first anniversary at the moment, and then some commitments. So then I'll be coming to suggest some actions that we wish to take as an organisation, some things that we're going to sign up to as a board, and then how we're going to check ourselves. So how we're going to continue to check ourselves over the next 6 months and the following 6 months, etc., as to how we're doing against this agenda. This isn't a let's put it on the board agenda in July 2020 and maybe remember to do it again in a couple of years' time. This will be something that we need to bring here every 6 months. Going back to your earlier point that you made, Alan, when the board pays attention to something, action generally will take place and will happen. So it's just setting out a bit of the scene for this presentation. So if I could take the next slide, please, or the first slide. So this is our National Staff Survey results for 2019 and gives us our benchmark against other acute providers across the health service in England as to where we are. And this particular bar chart on our left-hand side, as you can see, is our equality, diversity and inclusion position. So as I've pointed out previously in presenting staff survey results, the orange line is where we definitely don't want to be. The green line is where we aspire to be or above it. And the dark blue line is us, and the light blue line is the national average against acute providers. So as you can see here, this is made up of a number of questions which we'll come on to in a second, but we have some work to do across our organisation in this particular domain. If I could take the next slide. So then in breaking down those questions, the questions that make up the overall domain of equality, diversity and inclusion, again, these are just highlighted as to some of the issues that colleagues are bringing forward to us that we need to address. So we can see under item or question 14, whether the perception as to whether our organisation acts fairly, or the feeling as to whether our organisation acts fairly in relation to career progression or promotion, particularly for our BAME colleagues or any of the 9 protected characteristics. That has been deteriorating over the past couple of years, and we need to absolutely do something about that, which I'll come on to shortly in terms of some actions. And colleagues feeling that they've experienced discrimination from patients and service users has increased on the chart, but decreased in terms of has got worse. So it's increased, and therefore that's not good. We want to be in the lowest possible position for these next 2 questions. And similarly from colleagues experiencing discrimination from colleagues or managers, which is equally increasing, which is definitely not where we would like to be as an organisation. If I could take the next slide. And then the final question as to whether or not we can or are able to make reasonable adjustments to enable colleagues to carry out their work. So we're in a more favourable position in regards to this, so that's good. Let's celebrate some of our successes, and of course we'd like to increase that even more, and we have been attempting to as we go through the welfare risk assessment process. So overall, summary of context, we've got some issues that we need to address. If I could take the next slide. So in 1920, referring to our annual equality report, which is available for everybody to read in the public documents, there have been some actions that we've been taking. I've already just mentioned and called out the fact that our BAME network is celebrating its first anniversary at the moment, and that's great. And just before the pandemic really took hold of us as an organisation, we had launched our disability and LGBTQ plus staff networks. Clearly, we need to get those back up and running, as it were. The BAME network, I should mention, has been meeting during the pandemic, and we've been conducting those meetings virtually. Within the last year, we've also appointed Tim to his position, which is great to have that focus. And we've also looked at our workforce race equality standards, which I've picked up there, in conjunction with other items which are outlined in the paper. If I can take the next slide. So this is going to be very small, I appreciate, and we'll make sure these are circulated and put into the public domain. But overall, this is the ethnicity of our workforce. And I get asked this on numerous occasions in terms of the ethnicity of our workforce. And I get asked it in every single which way you can possibly think of. So I've given every option here. So whether it's by grade and where people work, whether that's in Agenda for Change or whether that's for our medical and dental workforce, whether that's the number or the profile of our starters in the organisation, the profile of our leavers in the organisation, or indeed the overall profile of our community, which is articulated here in this particular item. But essentially, from a BAME perspective, which we're going to go on to talk more about now, we have just over 23% of our organisation make up our BAME community. If I could take the next slide, please. So the welfare risk assessment process, I touched on this briefly in earlier items. When this presentation was put together just over a week ago, we were at 62% completion of welfare risk assessments, and I'm pleased to announce that that's increased even further. But I'm not going to give you a particular statistic because that's tomorrow when we take that account and submit it. But it's increased again once more, which is fantastic news. Similarly, it has the completion rate for our BAME colleagues, which currently stands at 85%. And as I said earlier, what we're finding from these risk assessments is some really helpful information going against those three things again, as to colleagues that are maybe suffering from mental health issues or support with their family, and how do we provide mitigation or support around those items. We have concerns particularly in relation to personal protective equipment, so PPE, where that should be worn and how it should be worn and why it should be worn. And thirdly, in relation to underlying health conditions. And we have noted some underlying health conditions that have been borne up by this process that we were unaware of beforehand. And so that's really important because that helps us to make informed and good decisions for colleagues. So the main diseases that are issued here are the ones that we're finding from our overall welfare risk assessments within our organisation. So the main underlying health conditions that we are working with colleagues is respiratory, immunosuppressed and inflammatory diseases. There aren't any particular themes or diseases reported out by occupational health, and by that what I mean is we don't have any huge mitigations that we're unable to put in place. So these aren't creating huge barriers for us to try and support colleagues to undertake work in their environment or in a different environment or in a different way and outside of the organisation. And feedback that we're having on the welfare risk assessments is really important. So I understand nationally that there have been some perceptions that this is very much a tick box exercise as opposed to an actual conversation. The strength of this is in having those conversations with colleagues and ensuring that people are okay and in their workplace. And some feedback here we've had from our local negotiating committee, which is our doctors committee, and our staff side, is that this isn't whilst it's a priority that we have these completed and understand the risks in our organisation, this isn't anything that's causing them concern from their members, which is positive. And the presentation articulates it shielding as our next focus, but it's very much a focus we've been working on in the past couple of weeks, as I mentioned earlier, so I won't go into that once more. If I could take the next slide, please. So then moving more into specifically our workforce rate equality standards for 2019, I'm going to hand over to Tim now, who's going to talk us through this work.
Thank you, Mark. Just before I start, I'd like to just articulate that the main purpose of the Workforce Race Equality Standards is to help NGH review its data against 9 RES indicators. It's also to produce action plans to close the gaps in workforce experience between white and Black and ethnic minority staff. And it's also to improve BME representation at board level of our organisation. The data that makes up the RES is primarily sourced from the electronic staff records, ESR, and the NHS staff survey. So in front of you, this is our data. There's 9 indicators there. As Mark's already mentioned, I'm grateful to support from our wonderful communications team that has helped me produce infographics that sets out the data quite clearly. I'm not going to dwell into too much detail, but indicator 1, you can see that our overall workforce is 5,118, and then it gives a breakdown of white BME staff. But working collaboratively with our BAME staff network, we've agreed that the focus should be on indicators 7 and 8. So indicator 7, that's the one that talks about staff believing that NGH provides equal opportunities. And as you can see, from a BME perspective, it's 65%, but from a white perspective, it's 87%. So there's a 22% gap there, which is quite significant. I think what we've got to do, following on from this board meeting, is drill down into that data across divisions and even professional groups to get a better understanding of why is there such a significant gap. Similarly, indicator 8, percentage of staff who personally experience discrimination at work from managers, leaders. As you can see there, if you're BAME, it's 20%, and if you're white, it's 8%. So we really do need to understand, why is that? Where is it happening? We are grateful already to the chair, who has produced a wonderful vlog that was circulated to staff. Hopefully staff, to encourage staff to let him know about their experiences working for NGH, but more importantly, to come up with some solutions about how we can address this. Because again, colleagues will be aware, was it Sir Robert Francis who produced a report into Mid Staffordshire hospitals, where he said, how we treat our staff is an indicator of how we deliver best possible care to our patients. So clearly, I think it's a wonderful opportunity for us to understand our data, but more importantly, to take action. So before handing over to the chair of the BAME staff network, I'd like Kieran to play the video, please, that has been produced by the BAME staff network.
Hello, my name is Liana Luxton and I am chair of the BAME group. I'm happy that NGH have supported this initiative to support the BAME staff in their trust and Northamptonshire.
Black Lives Matter.
Black Lives Matter.
Black Lives Matters.
Black Lives Matter.
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 Black Lives Matters.
Black Lives Matter.
Black Lives Matter.
Black Lives Matter.
Black Lives Matter.
All lives can't matter until Black lives do.
And thank you to everyone who contributed to that video. And thank you for having me. The recent events with Black Lives Matter and with the disproportionate effect of COVID on our BAME community has really increased our membership to the group. It's definitely increased mine and Tim's work that we've had to do. And that could be due to the fact of more adverse events happening, but also due to the fact of people feeling that their voices can and should be heard and that they will feel supported. So as a group, we have really focused on increasing our visibility and our support for our staff, our BAME staff that are part of the group and wider, but also with Tim, working really closely with him to really promote this agenda, and Mark, obviously. Without Mark, we wouldn't be here, really. So we've really recently supported a joint letter with the Chief Exec, and we've supported the BAME risk assessment process as much as we can and promoted it, the importance of it with our staff. And I think Mark pointed that out, that a lot of BAME staff felt that it was a tick box exercise and really communicating the importance of having it done, but also highlighting, if you feel it's a tick box exercise, why and how we can support that, and also the fit test process. And we've also been meeting virtually to really support the BAME group via Zoom, which has its challenges as well. But we have had support from our past Chief Exec, Sonia, and Mark, who have come to meetings. Matt Metcalf's come to meetings, so we've really felt supported in that way. And we do feel like it's an opportunity to change. We're kind of leaning on an open door, but we know we're really time limited. So I really as well wanted to thank Tim and Communications for their work on the Res Action Plan. And we have had our input into that. And I think from this meeting and from the Trust, we really want a commitment on that strategic level to that Res Action Plan. From an operational level, the BAME group has set up a task and finish group where we're really going to try and operationalise what bits of that plan we do and how we do them. And that involves us having real enablers put in place with learning and development, workforce, OD, to really help us push this agenda. And as we've moved into kind of living with COVID, our focus has, as it always is, on staff wellbeing and supporting our BAME staff through this time, but we have started to move back to the work we were doing before around work streams. So we have, as you see at the bottom of the slide, 6 work streams that we're working towards in terms of improving visibility of the network and engagement with all staff. We are really putting a call out for our porters, our doctors, all the people that we're really finding hard to reach. And as Matt said, with the BAME Clinical Fellow, that has helped a lot. With talent and leadership, so working towards improving and increasing our talented BAME workforce so that they can increase their opportunities to develop into leadership roles, developing staff group representatives across all staff groups in the Trust, changing behaviour, so that can be around improving allyship, but also awareness of culture and diversity, advocating BAME champions, and trying to figure out as a chair and as a head of inclusion and diversity and as a group how we support each other and what our real roles are in that. So just to summarise, at this meeting, I think the commitment that we're asking for is from the trust is to really think about what we as a BAME group do, what the trust board do, what governance do, what everyone's roles are in promoting that BAME, the Res Action Plan. That we can have a follow through on incidents that happen to set a standard for behaviour from the trust. So what we accept and what we don't accept. And just having some enablers. I think that there has been some barriers to even getting to this point. So to just enable the opportunity for our BAME staff to feel supported by the trust. And as I'm on a public forum, I just want to say that people can join the BAME group by emailing myself or by looking for us on Facebook and Twitter. So I'll hand over to Mark, who will go through some of the key actions that we would like to action. Thank you.
Thank you, Liana and Tim, and for all the work you do, and Liana for the promotional element there, right there in the end. Never miss an opportunity. Fantastic. So as I said right at the outset, there's some work that is being brought to our attention as a board, some work that we can do within the organisation, and then some specific actions for us to take across and around. Well, I was going to say the board table, but the virtual boardroom that we now live in. So in some work that we're going to do across the trust, and I think this is important because as Tim and Liana have articulated, this has come from our BAME network. This is where the solutions to those concerns come from. This doesn't come from people such as myself that have not experienced or do not have lived experience of what colleagues have been through in the workplace from a BAME background. So we're going to look at senior recruitment panels, including of consultants, in terms of how do we make our recruitment panels more diverse. So how do we have some colleagues from a BAME background into those panels, and how do we therefore ensure that culture and background is taken into account when we're looking to appoint colleagues. We have the establishment of new role models and for advice and support, and matters are already articulated earlier right at the top of our integrated governance report and his item on that. And a great example of that, and a really truly great example of that, is around our BAME clinical fellows. You know, we all have permission to act. Around this board table, we are the most senior people in this organisation, and where and when we see issues, we should be able to take action and not have to necessarily wait for permission. We are reviewing development opportunities. So it's all well and good, and many organisations would say, of course, yeah, we open our jobs to everybody, we put it on NHS Jobs, anybody's ever got an equal opportunity in order to apply. In terms of the application, that may be true, but in terms of the development opportunities to enable somebody to get to that application stage, we know there's inequalities in those. So we're going to go back and look at our development opportunities. Again, this is something that I'll be taking forward now in this role again across the group. So what opportunities can we offer across both hospitals, which will now be enhanced given the size of the group, and that we are now supporting 10,000 colleagues and a significant turnover. So we're going to also complete a review of those victims that are supporting alleged discrimination. So what does that look like? How is that happening? How does it manifest in itself? How do we support those colleagues? And one of the other items that we think is really important is the workforce race equality standards information being distributed at divisional forums. So how do we make this as prevalent, and how do I enable and support that across the organisation with colleagues from the executive team, in terms of as important as the vacancy rate in the organisation, how prominently are these statistics known, and is this information known within certain areas? And so we need to really focus on that, and that's something that's being strongly felt by the network. And to commit to the work streams. So how do we support people in those work streams? So as Liana's articulated, and she's a very organised individual, colleagues will undertake elements of work within those work streams and come up with suggestions. We need to support them. And by key people, that does mean senior leaders in the organisation, and that includes us. So how do we commit to each of those work streams when they come forward with ideas and suggestions, and give them our support in delivering what it is that they need? And a classic example of that, a very small one, is in relation to the communications team, and how the communications team have been very flexible in helping not just support the video production, but also the workforce race equality infographic, which, you know, if I'm saying it in public now, but from my perspective, we should have out and as prominent on Hospital Street as we have other information within our organisation. Then I move on to some of our specific actions for us. So some things for the board. The first one is a reverse mentoring program to be put into place. I reflected when this action was brought forward onto my own experience in the past year. And again, I could talk a long time about this and I will not, but I can assure you that it has had the biggest impact on me than any development program that I have experienced in my time in the NHS in the last 15 years. And it is hugely impactful to listen to a colleague giving you their perspective and their point of view as to what they have experienced within our workplace, or in this case within the county and the workplace. And it's very different to your own lived experience. It really makes you think quite long and hard about the privileges you've had in your life and how you may have got to where you've got to without even thinking about some extra steps that you, or extra push up the ladder you may have had. So there's a commitment. I also want to put forward a commitment at the board that we talk about diversity and inclusion 6 monthly. So every 6 months we will come here and we will give updated information in relation to diversity and inclusion, where we are against these items and these plans. The inclusion, we had some fantastic stories earlier this morning, one from obviously our patient and then obviously from our member of staff. It's the inclusion of a protected characteristic story in the board. So let's ask our BAME colleagues to come forward and give their story as to what their lived experience. As I say, there's nothing more impactful than hearing about people's lived experience. And to expand our network sponsorship, so not just our BAME network, but as I've also called out, our disability network and our LGBTQ network. Liana's given me a great example of this, which I'm gonna use now, and I'm going to use two really famous icons in the 20th century in these stories, and this one is Marilyn Monroe. So Marilyn Monroe used to attend concerts of Black artists and Black musicians back in the day, and she did that knowing that the camera crews and the filming crews would follow her there, and that would give exposure therefore to the artist that was performing. And I think there's something there for us about the leadership and the role that we have, the spotlight that is upon us, how we can support these networks, and by virtue of being there, that will give more belief and power in those networks to take items forward. And a commitment that our board development session in a couple of months' time, particularly in October, to focus on Black History Month, to give us all more information and education to, as I say, colleagues' lived experience of in the workplace and beyond. Because as Tim pointed out, and well, it was pointed out in the slide, but Tim was very subtle not to mention it, in terms of our board makeup, it is not as diverse as that of our organisation, and therefore it's important for us to receive some information and education as to experience of colleagues from in the workforce. If I could take the final slide, please. So how are we going to monitor our progress? So in the 6 months, how do we work upon our allyship, as I say, just mentioning the current makeup of our colleagues around the table. So Yvonne Coghill, who is one of the prominent figures in this within NHS England, has come up with this model, which we've looked at across our diversity and inclusion steering group, and would support. And again, I think it's fair to say we support across the group. So here in Northampton and over in Kettering too, that we have to have an appetite or a desire to improve. Do we want to improve our position from where we are? So I ask each colleague as I go through these to just think for a second for themselves. Do we want to improve where we are currently? How can we ask questions and be curious? Because we all have different experiences and different things that we've been through. But let's ask, let's find out, let's read some information, let's see, just to help ourselves be more educated in this particular area of diversity and inclusion. Let's accept there's an issue. So Tim's presented the res data. What I'm not here to do is to say that that's not true, or when I talk to people, that's not what people say. That is what people say. It's in black and white in front of us. So we need to accept there's an issue and therefore acknowledge it. So there's something that we need to do. We acknowledge it. We're not afraid of it. We'll do something about it. We need to apologize when we don't get it right, which we won't always get it right. We need to express sympathy for some of the circumstances that people have found themselves in. And we don't need to assume. So it's another reason for the board development session suggestion in October. We could seek views and opinions of colleagues. I'm sure Tim won't mind me saying, when we were coming up with some of the workforce race equality standards information, we had a conversation and I said to Tim, I'm not interested in creating the actions because it's the network that will do that. How can I know? Because I don't know what people are experiencing, and I won't be assuming that at all. And then we need to take action. So I've just talked on the previous slide about some actions that we can take forward, and you know, we need to demonstrate that and be accountable for it. And so what will we see? So in doing all of that, what will we see? What will be different in our organisation? What are we aiming for? So we will launch the unconscious bias development programme, and we will monitor how much that is, or how that is undertaken within the organisation. And we have the ability to influence certain criteria in that, such as once the development is up and running, an example will be in terms of recruitment panel. So no individual will be able to chair a recruitment panel without going through this programme beforehand. And unconscious bias is something that we all have, we all experience. Better that we acknowledge it and we know it's there, as opposed to try and ignore it and pretend it's not, because it will influence our decisions. Workforce race equality standards position improved from 65% of colleagues feeling that career progression is fair to 72. You could say, why is it not 100, or why is it not in the 80s, such as non-BAME colleagues? But we felt again across the group that we can take meaningful steps that we could deliver, as opposed to just 65 to 100 is not going to happen, and you know, we need to acknowledge that this will take some time. Our discrimination position being improved from 20 to 15% in terms of colleagues feeling they've experienced discrimination. And as we saw earlier on the infographic, it was 8% for non-BAME colleagues. But this could rise and fall. And this is a challenge that was being put to me in this. You know, there's always a desire, as we all know, around the board table, say, we'll get it better, we'll make it better. But the more avenues we open to colleagues and we demonstrate, the more tolerance of people bringing forward their concerns and queries and experiences, that will take action. We may see that people are more able to come, or more willing to come forward and feel able to, in relation to some of the discrimination they've experienced, and therefore we could see a rise in that number before we see a consequent drop. But we will continue to monitor that. We can and will have reverse mentoring in place. Obviously, I'm making an assumption that people are going to agree that, but there's a program again across the group that I believe we could roll out quite quickly, and by that I mean in the next 2 months. And continue to develop our board sessions on this vital work, as I said. And here comes the second 20th century icon that I'm going to talk about. So this is David Bowie, and this is why being part of the BAME network is so powerful, because you get to hear things from people that they've seen and they experience and they've resonated with. And this particular one actually came from Tim, which was back in the 1980s. David Bowie was being interviewed by an MTV music producer, who's the guy who chose what goes on at what time and what videos are shown and aren't shown. And he continues to press for 8.5 minutes, this producer, as to why videos by Black artists are only put on in the dark hours of the morning that nobody's awake for. Why are they not in primetime TV? And he continues to push and continues to push. And the reason for being more like Bowie and concluding this presentation is that that's where we are. We know where our position is and what can we do to push and make a change and be the change that we want to see. So that concludes our presentation. I just wanted to finish again by saying a huge thank you to Tim and Liana for presenting today and taking time out.
Okay, thank you very much, guys. I'm very much of a mind, and Mark said that when the boards of organizations start to really focus on something, things happen. And I'm not in the club that sort of says this will get better by wishful thinking. This requires us to do something. And I'm very conscious in my lifetime of the discrimination that was common against all sorts of groups. So I don't shy away from the idea of positive action and doing things that take this forward in a meaningful way. Any other comments on that at all? Tremaine, hardly surprising, but go ahead.
So firstly, I just want to thank Mark, Liana and Tim for the work you're doing. I think I'm in full support of all the actions stated, and actually sort of have a think about taking it further, in the sense that there's 3 things I'd sort of suggest. The first is, you mentioned, Mark, this briefly, but I think sort of deep diving into why this is happening, in terms of, you know, we've mentioned, look at patients particularly, and you saw that spike from, I think it was 2015 today, of increasing discrimination. And some of that, one of your A's was appetite. And I think we need to remember that we're in a position where we can educate patients. It's not always the right, you know, setting, but what can we do around that? I know often we talk about zero tolerance, but in reality, we've got care to deliver, and there's a challenge around that. So how can we support patients on that side of things and our staff? So sort of deep diving into that. The second is around, you mentioned equality updates every 6 months. I just wonder if there's an opportunity to really have an update to at least the workforce committee every month or quarter. I don't know if Anne supports that. I'm sure she's nodding. And the third is it's not completely contentious, but I'm sure you'll recognise this, is that one of the things COVID highlighted is that BAME as a term obviously is comprised of lots of different groups within that. And one of the things that COVID brought out is there is a big disproportion between each of those and how COVID was affecting, and it wasn't a blanket, every percentage affecting every group similarly. Asia is one of the most popular places in the world, made of lots of different countries. The same with all the other areas. So it's just a sort of question around how do we, I think that's more of a data question in terms of, I appreciate this isn't a sort of request or to change the whole structure of the BAME network, but it's more to sort of say, have we thought about how we maybe report? I know we only have control over some of our internal way of collecting information, but have we had any thought about how we segment to identify groups that maybe at even more increased risk that we haven't maybe picked up on? So those are my 3 comments.
Okay, thank you, Tremaine. Anne, and then John. Yeah, Anne and then John.
Hi, thanks Tim and Liana. It's great to have the BAME network at the board. And good to see specific actions. And picking up on Tremaine's point, we'd really like to have this as a regular item on workforce. And we are looking to have a joint workforce as well with Kettering. So this would be a perfect opportunity to ensure we're making progress across both trusts and that we're really sustaining the focus. I'd love to come and attend one of your network meetings, and happy to help and support in any way I can, whether it's coaching, mentoring or whatever. But I really, really want us to make a difference here. And I think this is a great start.
Thank you, Anne. John.
Thank you, Alan. One thing, I think we've really got to start at the top and make an effort at the board to get some BAME representation, get rid of some of us old pale males and find appropriate. I know it's not easy, but we've got to really, I think, push and make that effort, because I think if we show it from the top, then will start to filter down and it will send the right messages. And then just one point on data. On page 101 of the board papers, it says we've identified 1,983 BAME staff, and yet I think Tim was quoting a lesser number. I think we just need to check our data and make sure we do know how many BAME staff we have got.
Okay.
Yeah, I could just pick that one up quickly, John. So the 1983 number included all colleagues in vulnerable categories as opposed to just a BAME colleague. So that is a discrepancy. We can pick that up.
That's fine. Thank you.
Okay, Jill.
Thank you. Fantastic presentation and videos, much appreciated, and echo what everybody else has said. Just 2 other areas I think we could think about. One is not just across the group, but across the HCP. What are we doing about this across our community and working with the whole of our system on this as being a priority? And the second one is for us to think carefully about clinical service delivery and how potentially we might need to think about how we change that based on advice, particularly from our colleagues in the BAME network, and also public health information, etc. So 2 things that probably can't be answered now, but I think we need to think about really carefully going forward.
Okay, thank you for that, Tom. And then Simon.
Yeah, just Mark, I think I've remembered your figures correctly, just around one of your action points, which is around discrimination or bullying and harassment, where I think you said that the BAME staff experienced, quoted that as 20% in the staff survey and the white at 7 or 8%. And I accept that we want to have targets that are acceptable, and which is potentially why you've put to reduce it from 20 to 15. But I just wonder about that message coming from the board. I mean, it shouldn't be acceptable for any member of staff to come to work and expect to be discriminated against or bullied and harassed. And if we're by default condoning a position where we think it's acceptable for 15% of our BAME staff, but only 7 or 8% of our white staff, I don't think that's the right message. I think we should be saying that, you know, this is unacceptable. And you should not expect to come to work and be bullied or harassed more depending on the colour of your skin. And we should stamp down on it. And the way to do that is to say we will tolerate no difference.
Come back on that, Mark.
Yeah, I can come back on both. So thank you for all the comments. I suppose the reason for I totally agree, Tom, from a perspective of zero tolerance. The reason why we felt that was a more feasible statistic is just because to demonstrate some improvement, it's going to take some time to help support and educate people and to help bring those colleagues forward who are suffering discriminations. But I don't not take your point. It should be zero for everybody, including the 8% of white colleagues that experience some type of discrimination. So I totally agree for that. But we were just trying to work on an incremental progression. So how can we demonstrate we're making a difference? And what is it when we come back in 6 months? Because in coming back in the next res data, it's very unlikely it will be zero. And so what is it we can try to demonstrate through the network we're having an impact upon? In terms of the point, Jill, around the regional and the system work, there is absolutely some work we started on that. So within our system people board, we have a domain under staff health and wellbeing, of which diversity and inclusion and our BAME support is part of that. And then that feeds up to the regional people board, for which I'm now the member of the county of Northamptonshire to support that regional people board. And our very first meeting last Tuesday was spent challenging the makeup of ourselves, because it's a huge agenda item for us as a regional across the whole of the Midlands. And when you look around, there wasn't much diversity in the room. So our chair was very pushing of that, rightly so, in terms of how do we change that and what do we do? How do we help bring people forward around that agenda, and indeed nationally. So Tim, Liana, Carol, Shri and I from our Kettering organisation attended a national webinar last Thursday evening, of which there were over 300 colleagues part of that, the national people plan around what we're going to do about this agenda and what we can learn from each other in relation to our experiences. And I think just in terms of benchmarking ourselves on that, we are nowhere near the top, but equally, thankfully, we're nowhere near the bottom in terms of not having a network, not starting any of this work. We're probably in and around that middle place, and we want to be better than that. We aspire to be better than that. Hence the work we're undertaking. But as I say, there is a national, regional and system approach to how we tackle some of these issues.
Okay, thanks for that, Matt. I think I share Tom's concern about flagging up a target of 15. I don't mind a milestone on the way, but I think we need to be careful how we present that. And I was going to come to Simon. I'm going to keep Simon for the end, because that's kind of what his privilege is. So Denise and then Matt.
Yeah, I think mine's been covered. You reiterated what Tom had said. I'm uncomfortable with having that as a target. So I think we need to sort of think about how it's positioned, sort of understanding where it came from. But we're aiming for zero. So I think that needs to be reflected somehow.
Okay.
Thank you.
Matt and then Tremaine.
Thank you, Chair. So first point, really to echo what Bob, yourself and Denise have said. I think I understand entirely the genesis of a target and an objective milestone to set, but I think the messaging and the optics essentially saying the risk of being perceived as saying we think it's okay to have discrimination twice as high against people from the BAME background as white people, it would be the wrong transmit really from the board. And secondly, I think Mark's point that we may experience before an improvement in that metric, a deterioration on the basis that people are currently unwilling to come forward for fear of retribution. I think that is likely to happen, and I think we should expect it and understand that will happen. From my conversations with BAME colleagues and attending focus groups, etc., that's a theme that comes out over and over again, because one of my questions was accepting my responsibility for not being aware of the issue as much as I could helpfully have been previously. Why have I not heard more about this? And the answer that comes back time and time again is nobody wants to tell you because nobody wants to be on the receiving end of retribution. So I think Mark's right. I think the metrics will get worse before they get better, and we should expect that and almost welcome it as lifting the lid on the issue.
Okay, thank you, Matt. Tremaine, and then I'm going to wrap it up and go.
I was just going to say, I think it might be worth framing this as just the target of reduction in each for each year. And I think the comment around this from Tom is well received, because I think something I've observed in other trusts is that the bench, and I'm not suggesting we're doing this, but when you look at res data, one of the targets of other trusts is the way other trusts deal with it is to try and achieve the benchmark in the sense of being not more racist than other places. But I think we need to reflect, effectively aim for equality, not for racism, which is clearly the message that's coming out from everyone. Yeah.
Okay, thanks. Simon, finally.
Thanks firstly for the presentation. I just wanted to echo what others have said. It's really thought-provoking and challenging. I just want to make it real with a couple of personal commitments, I suppose. So we're going to be making some important group appointments probably in the later part of this summer, and I wanted to be clear with you all that we will not do that. I will not do that until we've done that unconscious bias training and we've implemented the recruitment challenge that you set us, because if we don't get it right at the top of the organisation, why would we expect anybody else to follow our lead? So I've said that out loud, and I will also commit on my return from leave to talking to colleagues and getting my reverse mentor in place. Mark has been rightly challenging me on that, and it's important I demonstrate again that I will make that place for myself. I do think I've had the opportunity, as has Mark, to last thought to look at the challenges and opportunities that exist in both organisations. And I think one of the things that I'd like to think we could do is how do we, across Northamptonshire system, start talking about this much more. That's, I think, not just at the people board, but between the group, there are lots of similar stories and lots of similar opportunities for us to share and learn from. So I would hope that as we go forward, this isn't just an NGH or KGH story, this is our story about how Black Lives Matter in this group, and that's something I think we should make a long-term commitment to. And just again, final words from me on this, I want to assure you, I suppose, that we will bring this back, because this is, as Alan said, not the journey of a single step or 10 step, it's the journey of 10,000 miles, and we need to start it now, and we need to be consistently coming back. It will iterate, it will change, and I will look to your leadership in this to constantly challenge us to continue to develop this programme of work as it goes forward. But thanks from me.
Okay, and thanks from me as well. I thought it was a good conversation. We're well over time, but I don't regret that at all. I think it was worth the time and effort to talk about it. I think all the points people have made will be picked up on, and I look forward to having further conversations with both Tim and Leanna. I think Leanna's nearly sorted her one out with me, but I look forward to seeing it in other places. So thank you very much, everybody. We can take that forward constructively. Okay, good conversation. Next item, Freedom Speak Up Annual Report. Claire, this is pretty quick stuff, and it's a living example really of when people say this will get worse before it gets better. Everybody keeps telling me it's a good thing to have more people doing freedom to speak up. I ever get ever so slightly nervous about this proposition. There must come a point when it ceases to be a good thing and starts to become a bad thing, and it'll be worth thinking about where that is at some point. But Claire, over to you as our Futsu.
Thank you, Chairman. I think your point's well made. I'm pleased we've had an increase because when I first commenced in post, we had a very poor freedom to speak up numbers in this organisation, and the last year has been a lot of hard work of raising the profile, so you would expect to see things come up. So I was very pleased with that. I would say coming into this year, it's difficult to say whether that's reducing because clearly the first quarter was COVID, so things did reduce anyway, but I would hope to see a plateauing, and we should have approximately, for a trust this size, 45 cases per annum. So that's kind of the benchmark that we're looking at, or that was the previous year's benchmark. You will note that the same as previous years, most cases identified have been bullying and harassment, with the second highest on patient quality and safety. I've had a lot of support this year from ambassadors, and the one plea I want to put out is I do need to reset the ambassador training going forward, and I do need some BAME colleagues to join that. And I think Leanne has gone off the call, but I will be going to meet with her, hopefully to virtually to attend one of the meetings and engender some support there as part of the increase in staff group representation she referred to in the presentation. You will see there also that we have had the higher proportion of staff issues being raised from the midwifery section. That has now been seen to reduce in the new year. That's all I propose to say. I'm pleased with the progress made. Lots more work to do. So that's, where we are currently. Happy to take any questions.
Okay, thank you very much. I think that's pretty much how the rest of us see it at the moment. Yes, all happy to accept the report. Lovely, thank you very much. National Inpatient Survey feedback. Sharon.
Thank you very much, Chair. I just wanted to flag the immediate results up to the board. These were published the beginning of July. The National Inpatient Survey is an annual mandatory requirement by the CQC. The scores or the results which were published in July, early July this month, reflect patient experience from June 2019. So quite a considerable time ago, from patients reflected on their experience to us getting the results. So really the headlines for us are that nationally, the response rate was 45%. Our response rate was very much akin to that, being nearly 44%. The survey itself is broken down into 12 sections, and within each of those sections are a number of questions, making 63 questions in all. The scores that you receive a real number, but they're also broken down into whether you are about the same as other trusts, you're worse than, or that you're better than. And I'm able to report that the trust scored relatively the same as what we did last year. 10 out of the 12 sections, we were comparable with other trusts, about the same. And in 2 sections, we scored worse than other trusts. Those 2 sections were 3 questions relating to doctors, and there was 1 question related to overall experience. Of the 63 questions, 4 questions, we scored 9 or above, which implied that our patients were satisfied with receiving necessary information and being given enough privacy when they were being examined or treated, for example. I'm not planning on going through my paper in any further huge detail, but suffice it to say that there are 3 priority areas we need to work on: communication, doctors, and discharge planning, particularly our patient involvement and information in discharge planning. We started a number of work streams following the receipt of our results last year, which have already been put in train, but have somewhat been hindered by our COVID lockdown situation. But what is important to note, and we will be doing, is we'll be doing further analysis of the feedback. We'll be feedback the results into the divisional teams. It needs to go hand in hand with our staff improvement. And we also need to include this in our hospital reset work as well. So as when we're pressing the buttons to reset our services, we're also considering improving our patient experience. The future of the inpatient survey is also going to change. We know that it's not going to be running the same way as it's been run previously. Questions are likely to change, and the reporting period is likely to be the tail end of this year, just prior to Christmas, but we're awaiting further information on that. So that's all I wanted to say at the moment, Chair. Lots of work to do picking this up, but I just wanted the board to be noted. Thank you.
Anybody comments? Tom?
Yes, sorry, Chair, and thanks to the nursing director. Just to highlight that we also talked about this in some detail at QGC last week, Chair, and just we noted the kind of must-dos around medicines management and within the CQC report, and that there was just a question around medicines in relation to the patient experience that we saw where we were performing worse than other trusts. So it's just to note for the board that that was picked up at QGC, and we're going to have a bit more of a focus about medicines management more generally within a future QGC meeting, and the nursing director was very comfortable at taking that forward for us.
Okay, thank you, Tom. Anybody else? I suppose my only comment on this is let's not argue with the data. It says what it says, and it's got some messages in there. So as part of our reset, part of our culture issue, part of all the stuff around bullying, harassment, relating to patients, patient experience and everything else, let's just absorb the data and react properly to it, not defensively. Okay, thank you very much, everybody. We don't have any questions from the members from the public. Is there any other business that anybody wants to raise at this point? I'll take that as a no. Thank you very much. Can I now ask the board to pass the resolution to exclude members of the press and public from the remainder of the meeting, having regard to the confidential nature of the business? A nod will suffice. Good, thank you very much. Kieran, if you would move to exclude all other people, that would be very helpful. Thank you very much.